Good morning, everybody. Welcome to our session this morning on COVID-19, what we've learned. We're pleased to moderate. My name is Haley Gershengorn. I'm joined by my co-moderator, Margaret Herridge, and we welcome you. Our first speaker will be Manu Malbrain from Ghent, Belgium.
Good morning, everyone. Cheers. I'm Manu Malbrain from Belgium. And during the first wave of the COVID pandemic, I was the ICU director of the University Hospital in Brussels. So I will talk about how COVID changed ICU management. I'm not going to talk about COVID treatments. Those will be dealt with in other sessions. I also recently started as chief medical officer of a medical data management company, and for my research, I'm affiliated to the University of Lublin in Poland. To err is human. Humans do make mistakes. And in the first wave, we made a lot of mistakes, but we should forget about the mistakes and remember the lessons that we can learn. Leadership, or when it comes to being a manager of an ICU in times of COVID, I think it's a process of social influence which maximizes the efforts of others towards achievement of a goal. And for COVID, it was a common goal to beat COVID. In January 2020 was a Chinese colleague, and he saw that change was coming ahead in Wuhan. And we've seen in a couple of weeks' time that a whole new hospital was built. And I think this is an excellent example of resilience. But COVID is more than just resilience and changing and building new hospitals. I think it was about a potential for transformation, symbolized by the change of a caterpillar to a pupa and the transformation from a pupa to a beautiful butterfly. When we are in change mode, our focus is on the past and the desire to improve the past. But when we are in transformation mode, that's the future that directs our actions. So the clock was ticking back in January 2020, and we know what happened afterwards. So today it's about the lessons learned. I'm not going to talk about treatments, as I said, but I think this is a very nice paper showing how COVID impacted that we need to have more effective triage in the ICU, a systems approach to critical care crisis, effective epidemiologic registries, agile trials in a rapid way, expandable ICU beds, better end-of-life care and making tough ethical decisions, efficient supply. It was a logistic nightmare. We saw a digital transformation, expandable ICU staff, a new way of designing the ICU and of restructuring multidisciplinary rounds, with more focus on the well-being, also for the patient, the relatives, and the ICU staff. So COVID-19 was disruptive in all ways, not only for the patient, but also for healthcare, society, hospitals as a whole. So I'm not going to deal with all the symptoms and the impact, but I just highlighted in yellow some of the topics that will be addressed during this session on delirium, how COVID also affected children. I'm not going to talk about a lot of respiratory effects. I'm just listing it here, the disruptive nature of the COVID pandemic. We'll hear a bit about enteral nutrition and biomarkers. To me, what was striking was the do not resuscitate orders, the ethical decision, and the futility of care. We'll see a bit about ICU resources and how the army can play a role. Never forget the family and the relatives and the psychological impact of the healthcare workers. For me, my personal bias is abdominal pressure and fluid management. I think what we saw in the first wave was giving maybe too liberal fluids, especially in the obese COVID patients, having dramatic effects of fluid accumulation syndrome and a global increased permeability syndrome. But today, let's focus on the human capital. And we see now, after the third, the fourth, the fifth wave, that nurses are falling out, they're stopping working in healthcare, and we have to close beds in the ICU. This in conjunction with human factors, which are the non-technical skills of our doctors, nurses, healthcare workers. So these are just 20 personal ideas, messages that I recall. When it comes to the chain of command, I think it was important to have a single line of command. Hospitals usually are hierarchic structures, so you need a crisis unit with someone in charge, but at the rest of the organization, it was rather flat and people working together from nurses, cleaning women, logistics, pharmacy, and so forth, trying to find a coalition of the willing, never forgetting patient and family, creating a coalition of the winning to beat the virus. So for this, we needed to have good guidance, good protocols, and uniform way of decision making. This meant that we needed to narrow the bandwidth of what we could do, how to treat the patient, and sometimes it got very dark and we didn't know what was coming, we didn't know what to do. But I think there was always light at the end of the tunnel when we were focusing on teamwork. If you show this slide, everyone believes he's a success team, but I think COVID showed us also the things that didn't go well in hospitals and units. And then it comes sometimes to status and ego and power. Trust is not the same as trustworthiness, whereas trustworthiness is credibility, reliability, intimacy, which is the empathy that we can show as healthcare workers, divided by the self-orientation. I think COVID skipped the self-orientation and we had to go for teamwork. It were times that you could show yourself as a leader, as a director of a department, to be fragile, vulnerable, not knowing everything, which was the place for authentic leadership. COVID forced us to leave the old paths and to change. And there was a lot of things on our plate that we had to deal with. So we had to prioritize our actions, decisions, and the use of our resources. And I think it's a nice viewpoint by Jean-Louis Vincent, focusing on the 4 Ps. So the first P is the preparation. And some things we did well with the expansion of ICU beds, but I tell you later that this also had a drawback when it comes to mortality. We didn't do so well with the psychological support initially for patients, relatives, and healthcare workers. The progression, we understood better the pathophysiology of COVID, but we could maybe have done better with respect to international collaboration early on. Albeit the fact that we need to follow the guidelines, there should always be room for personalized and individualized care. So I think we understood better the phenotypes and the individual responses of the patient and to titrate the management accordingly. And the prioritization, I think development of guidelines we did well, but we lagged behind with respect to ethical decisions and resource allocation. And then it comes to culture, which is the sum of the individual behavior of the people working in an organization. And we know that culture eats strategy for breakfast. So when it comes to change, the heart of the matter or the heart of the challenge is the human one, because people, they just don't want to change. And the most dangerous phrase in the language is, we've always done it this way. So there were non-believers. And in order to get them on board, there was need for coaching. And I would say there is a rational coach and a relational coach. And this is referred to as the golden triangle, which is culture, leadership, and vision. So leadership normally creates commitment for results, which is your strategy that you're aiming for. And usually, in non-COVID crisis times, we spend a lot of time in creating this commitment, maybe around 75%, whereas the results only follow afterwards, maybe 25%. And I think COVID forced us that we needed to get quick and better results to create value for the shareholder. So communication was key. We needed to be transparent in our communication. And just show you a result of a survey of the Fluid Academy. If you look at the Net Promoter Score, how was Corona communicated in your country, it's -21. So people were not happy with the way that the COVID pandemic was dealt with, and also in hospitals, poor scores. So this is the perception, what we felt. We needed to make things visible, and I think Italy was 2 weeks ahead of Belgium when we saw the images and devastating, the army, I think, and the call from the ISICEM president, we got ready. But we got ready in the ICU, or we wanted to get ready, and the hospital management thought that we were panicking, that we were exaggerating. And some may have said this is fake news, and then it comes to ego and power, internal politics. But I think in the first wave we were able to break down the walls between the different departments, the ICU, the post-anesthesia care, ward, medium care, and so forth. I recall nonchalance, some citizens who were not wanting or willing to follow the rules with respect to social distance and masks. There may have been some arrogance or ignorance. In Belgium, we also had the external politics. It's a small country, 11 million citizens, but we have 9 ministers of healthcare. So during the first week, it was terrible to get a patient transported from one region to another. And we've seen a lot of bad leadership, although if there was ever a time for authentic leadership, I think COVID, this was the time. Empowerment of nurses, these are midwives who were helping with a call center to get in contact with the family and the relatives. There was time for innovation. Very fast, we were able to get interleukin-6 measurements, procalcitonin measurements in our hospital, which were not available before the pandemic. And there was a lot of learning, education, and training, like introduction of telemedicine, virtual reality glasses to get connection with the relatives. And innovation. In a couple of weeks' time at the university, we built a ventilator, which fortunately was never needed to be used afterwards. This is the drawback I would like to show in this study on COVID outcomes in Belgium. You can see on the left there is a widespread in odds ratio for mortality between the different hospitals. And on the right you can see that the hospitals that created more ICU beds, so with an increase in 60%, you can see that mortality for COVID patient goes up to 50. So all these points, is this the new normal? I don't know, future will tell, but I'm afraid not. I think after the first wave, soon there were some walls built again in between the departments, and it was more difficult to get help in the ICU from other departments. So we may head for business as usual. To wrap things up, I think for me the key messages from the COVID first wave was delegation, adaptability, resilience, agility, and serendipity. So delegate, I think it's important, the teamwork and the communication I would highlight. When it comes to adaptability, you've seen the review from Yassine Arabi with all the fantastic things that we adapted the way we treat our patients, but I think it may be hindered by ego and power. Resilience, I think their resistance may come from culture, not wanting to change, and the internal, external politics. For agility, I would refer again to the 4 Ps on preparation, progression, personalization, and prioritization. And serendipity, I think it's a beautiful word in English. We don't have such a thing in Dutch, I would say, but I think this is the empowerment and the innovation that we've seen and the digital transformation that came to speed. So the bottom line is that we would like to improve health as a whole. to enhance the patient experience, to enhance the work-life balance for the healthcare worker, reduce costs, and achieve equity. Equity, which is totally different than equality. Thank you for your attention.
Thank you very much. So we have opportunity for one question, and then we have some discussion later if anyone in the audience has a question for Dr. Malbrain. Otherwise, I'll take the opportunity. So one of the things that you mentioned, which I think has been challenging for all of us, is the need for preparation as one of the 4 Ps, but now what we're facing with staffing shortages that we can predict. And I'm curious, as an ICU leader and as someone who's thought about this, if you have any strategies for us in preparation for even the new normal or the next wave, how we deal with these staffing shortages and how we try to prevent them from worsening.
That's a key question, and I don't have a clear answer on that. It's a lot of effort trying to convince people to stay. I think we're discussing with the government with respect to the first previous waves, there was always this surge capacity where we need to block and reserve ICU beds, hospital beds. So we would like to step away from that and then just depending on the severity of future variants, whether they will be sicker than the ones we see now with the Omicron, but to treat it as we would treat other patients in isolation, like MRSA or. But for the nurses, I have no idea.
Great, thank you so much. And it's my pleasure to welcome Dr. Sam Hutchings, who comes to us from King's College London. And Dr. Hutchings is going to talk to us about how the military can help us. Welcome, Dr. Hutchings.
Thank you so much. So, thank you for asking me. I am a military intensivist, but I work within the civilian healthcare system in the United Kingdom at King's College Hospital in London. So just a brief overview of my career to date, just to give you a bit of background on my military role. This is my first job in the military, which was as the doctor on a ballistic missile submarine. And then I've done operational tours in Iraq and Afghanistan and Sierra Leone. But I've spent the last 11 years as a consultant, predominantly at King's College Hospital. And I have to say that compared to all my operational deployments, the challenges of COVID were really the most challenging thing I think I've done in my career to date. I just wanted to mention this person. I'm going to talk a lot about how we adapted a military framework to a civilian response, but this is Lieutenant Colonel Claire Park. She's one of my colleagues at King's, and she's certainly equally, if not more, responsible for all these changes than I was. So this is a heat map of London. And the 2 red dots you can see here are the 2 hospitals that our trust is responsible for. King's College Hospital in the centre is a large tertiary centre. And then the other red dot, which has been subsumed by COVID cases, is a kind of satellite district general hospital. And this is wave 1, and this is patient admissions. This is patient admissions by location. You can see the sort of overwhelming effect that we saw, and I'm sure all of you saw as well in your institutions. And this gives you another way of looking at it. This is the daily admission rate in wave 1 and wave 2 of COVID at our institution. So we peaked in wave 1 at 12 admissions in one day to our critical care centre, and in wave 2, 19 admissions in one day, which compared to our normal mean is probably 2, 3, 4 on a bad day. So it gives you an idea of the kind of overwhelming impact this has on a system. And these are the changes in wave 1. We went from 64 beds to 162 beds. And we went from 4 ICUs to 9. We use the word ICU loosely, but 9 areas where we were providing critical care. And this is the same data for wave 2, presented in a slightly different way. But at the outset, again, wave 2, we've kind of reset down to our standard bed frame, which is 63 beds, rapidly expanding, 89 beds 119 beds, to a peak of 173 beds. The plus 36 bit there is patients that were being managed outside of the ICU essentially by our outreach service. So we had patients on CPAP and high flow oxygen, as I'm sure many of you did, not managed within a critical care setting, but managed by our very excellent outreach nurses outside of ICU. So this gives you some idea of the kind of system changes that were taking place and how difficult it was to potentially manage those within an existing management structure. So I remember sitting in an office, I share an office with my clinical director, I sit opposite him, and obviously all hell was breaking loose in this time 2 years ago. And he said, what will the military do? Put your military hat on and tell us what you do. So there's me in my military hat. And so we came up with some aims. This was me sitting at a desk, and I remember this very clearly. I spent a whole day sitting at a desk surrounded with bits of paper, drawing on it with highlighter pens, trying to create flow diagrams and just trying to work out how we were going to do this, how we were going to introduce some kind of new structure. And these were the aims that we came up with. The first one was to depressurize our existing senior critical care leadership staff, because really we wanted them to focus on system expansion, not tactical command. And the problem was that we were being overwhelmed with patients, and the key thing minute to minute was where we're going to put the next patient. But we needed to be thinking, what are we going to do in a week, in 2 weeks, in 3 weeks? Where are we going to open the next ICUs? So they needed to be doing that, and we needed to have people that were doing the day-to-day tactical decision-making. We needed a workforce model that enabled as far as possible for us to deliver the same standard of care that we were used to delivering. And as difficult as that was, I think we managed that broadly. And also to, sorry, I'm just going to read that. So there was significantly reduced time available for stakeholders to make key decisions. So things were happening extremely quickly, and we needed a system that took account of that. So what we did is we split the service into a tactical hub, which was a more strategic, outward-looking system, and a tactical team, which was responsible for day-to-day, minute-to-minute decision-making. And that tactical team consisted of a critical care consultant, and there weren't many of us who did this role. I think it was fairly self-selecting. There was the 2 military consultants that worked in my institution, and then eventually 2 others took on that role as well. But I think it's fair to say, and reflecting on that, there was some controversy about that, because this wasn't really a democratic decision-making process at the end of the day. We kind of self-appointed people who would be good at these roles, or we thought would be good at these roles. And that did cause some challenge, because healthcare is not a military structure. It's not a complete top-down hierarchical rank-based structure. It is much more horizontal than that in reality. But when you come to a situation like this, I think you do have to revert to a structure that is more hierarchical. But that did cause some problems with some colleagues. We had a senior critical care matron involved in this team and a bed manager. And really, we spent the whole day together. So those 3 people were basically just going around, making decisions minute by minute. And that interfaced in with the stuff that I'm sure most people did. We had individual proning teams that interfaced with individual clinical areas and hubs, and our external critical care service. So what were the functions of this tactical team? Well, I've covered a lot of them already. It was coordinating movements of patients around the hospital to facilitate particularly specific interventions. So particularly renal replacement therapy, we could only provide in certain of the critical care hubs. And we often moved patients around based on their need for renal replacement therapy. As you'll see in a minute, I've got some slides on this, but we had a very high instance of renal failure requiring RRT at our institution during wave 1, which I think was slightly unusual. We certainly didn't see it in wave 2, but that was the major challenge that we had. And there was a lot of movement around with patients to try and facilitate that. We had to interface with individual clinical area leads. Often these people weren't intensivists. We had about a third of our consultant workforce during wave 1 and wave 2 who were consultant anaesthetists. Who'd had a bit of critical care experience, but maybe not contemporaneous. So it was a lot of time supporting them. Workforce was a major thing, as we'll see. So we spent a lot of time just writing rotas. In fact, the senior nursing staff basically spent all their time writing rotas, trying to fill the next shift coming up in 4 to 6 hours' time. When I set out to do this, I had an idea that this would be amazingly sophisticated, and I would have a data person following me around with an iPad who would I would say stuff and they would just do stuff and it would all work. And that's what actually happened. In my office, I have like a personal testament to the COVID pandemic, a stack of these things that I can't really bring myself to throw away because everyone sort of tells a story. They're all dated. You can see, interestingly, that I've decided to skip ahead a month and on the 30th of March decided to make it the 30th of April, which was wishful thinking, I think. And the other thing I noticed when I pulled this out the other day is me trying to explain the difference between exponential growth and linear growth to somebody on this chart. And fortunately, it turned out to be at this stage more linear than exponential, which was good. This is something else we do in the military, a daily battle rhythm. It sounds a bit militaristic, but essentially it's just a very structured way of going through a day and trying to do the same thing every day. So everybody knows at this time of the day you have a meeting and this is the things you discuss. And so particularly we discussed a lot of tracheostomy timings. We had colleagues from MaxVac surgery there. We usually do most of our trachees percutaneously, but in the pandemic, we just didn't have the capacity, so a lot of them ended up getting done surgically. So there was a lot of interdisciplinary discussion there. And prone position. So proning was a massive logistic problem. The peak of wave 2, we proned and unproned over 30 patients in a day in our institution, mainly done by advanced critical care practitioners. So that was quite an important bit of this daily battle rhythm. Just briefly, this is the thing I talked about with renal. We had to do some pretty interesting things with renal provision. We did acute peritoneal dialysis, which was just phenomenal, and actually worked amazingly. But we also used intermittent hemodialysis, and we actually created 2 hemodialysis units within our institution, plumbed in the water, and had to create rotas for patients moving through them. And you can see here in this slide the provision of renal replacement therapy by CRRT, but then by PD, which is in green, and by intermittent dialysis, which is in blue. So the other thing I just want to talk about, probably to finalise this, is the more strategic structure. So the military looks at staff provision in this kind of broad way. They subdivide the staffing of military operations into these domains. So you have J1, which is personnel, J2 intelligence, J3 operations, J4 logistics. And people sit in a room, they literally sit in a room surrounded by computers and maps and charts, and they all interface with each other. And this is the structure that we really wanted to recreate. And we did it to some extent. I really wanted the room concept with everybody in there, so you could just walk into the room and you could speak to the person who was responsible for this domain and get what you wanted. Now that got a bit clobbered by COVID because we all got COVID and everybody stopped wanting to sit in a big room together. So it ended up being done virtually. But this is a legacy that has actually been maintained in my institution. We still have twice weekly tactical meetings. We still have this kind of structure in place. So just quickly to whiz through these. This is the most important bit, J1 personnel. And I've talked about a lot of this already, but medical and nursing staffing, workforce, rotas, took up a huge amount of time. Well-being and psychological support took up a lot of time. Phoning people up at home, are you okay? Why are you not at work? Do you need a test? You know, when can you come back? That was somebody, we just had somebody on a phone just doing that for weeks and weeks and weeks. Intelligence in this context was data. So data. We were constantly trying to work out what we needed, and we were constantly talking to other people in the network about how many patients they had, how many patients we had, and did we need to transfer people. And our clinical information system needed to be expanded enormously. So when we first started, we didn't have all of our areas linked into our clinical information system. And that was awful, because if you didn't do that, you had to physically go to the place, put on PPE, count patients, work out who needed proning. Once you had everything linked up to our clinical information system, it became a lot easier. Operations, policy and plans sort of lumped together. This is really what the more strategic outlooking bit of it was that I wanted my clinical director and our senior leadership team to focus on. You know, when do you open new units? When do you close units? When do you escalate and de-escalate? And that needs a lot of forward planning. Logistics, well, I mean, you only need to look at what's going on in the world at the moment to see that a military operation really stands and falls on its logistics. And the same was true in the pandemic. This is the thing, other than workforce, that really clobbered us. We ran out of renal replacement fluid. I got a phone call when I was on call at 1 o'clock in the morning saying, we've got no filter fluids left. What do we do? And I said, you've got to go around and triage the people you think can come off filters, and then we'll deal with it in 6 hours' time. But that was the key logistical pinch point for us, and we solved that by, as you've seen, adapting our renal replacement therapy strategy appropriately. Sedatives, I'm sure most of you had this problem as well. We used a bizarre sedative cocktail because we just ran out of the usual stuff. And tracheostomy tubes. We just didn't have enough to do the trachees we needed to do. Communications, absolutely vital. Manny showed you a slide of relative communication, and I think this is something we realised at the outset was going to be a massive problem, because we're all used to just talking to relatives every day as part of our day-to-day working lives, and that just wasn't feasible. And so we set up, as I'm sure many people did, family communication teams, and they're absolutely vital. But also communication within the service was absolutely vital. People just wanted to know what was going on. People would come up to me and say, Sam, when's this going to end? When's it going to end? And I said, I don't know. But you need to communicate the fact that you don't know to other people. Otherwise, they just sit in a silo and nobody knows what's going on. So we did this with a sort of daily briefing every day. The tactical consultant would write an email and put it out. Finally, training, obviously very important, but not much time to touch on that. And just in the last 3 seconds, we actually did pretty well. This is the ICNOC data from my institution. You can see that the busier units are on the right of the scale, and the standardized mortality plot, you can see we were sort of on the good side of that. So despite all the challenges that we faced, we did actually still seem to do a good job. Thank you very much for your attention.
Thanks so much for a wonderful talk. We have time for one question from the audience. Perfect. There's someone right here. Get you the microphone. Excellent. Thank you.
Thank you, Dr. Hutchings, for your explanation lecture. How did you organize the psychological support of your team? You talked about people being called up, about communicating yourself, but did you use a psychologist also?
Yes, yeah, we did eventually. That took some time to come in, and that's now established in our institution as part of our normal practice. We have 2 clinical psychologists who are actually now embedded in our team. I mean, they cover obviously patient support predominantly, but also staffing support. That took quite a long time to come through, and in the pandemic itself, they did come in within wave 2. Often I think it was quite difficult for them to find a role. I mean, they would come to our sort of daily briefing meeting in the morning and sort of say, hi, we're here. But I think there's a barrier, I think, sometimes to people actually then saying, well, you know, what help do you need and how do you actually interface and approach those people, which was quite challenging. I mean, like most institutions, the trust I work in set up, you know, what they call well-being hubs and, you know, all of these things that give you free coffee and stuff like that. I mean, it's a personal view. I'm never sure how valuable that kind of thing is. And interestingly, and this relates back to the question you asked at the end of the last session about how can we support our nursing staff and how can we stop our nursing staff flowing out. I got asked that same question by a government minister. In wave 2, I had to brief an armed forces minister about armed forces support. And he asked me exactly the same question. And I said, my personal view, you just need to pay them more money. Because all the pens in the world and all the badges that say, we value you, people, I don't think that really means much to people. But if you could physically reward them in a way that shows that they are valued, that would be my solution. That wasn't the answer the UK government wanted to hear, unfortunately, but that's my view. Thanks.
Thank you so much. Wonderful. I get the privilege of introducing our next speaker. Dr. Marcio Ciccone is joining us from Milan, Italy, and he'll be speaking to us about how to use rapid education to save lives.
Good morning, everyone. I will be telling you the story about what we did with the European Society of Intensive Care Medicine to try to bring information and some training during the pandemic. So our story in Europe started on the 20th of February. And in Italy, actually in Lombardy where I work, an intensivist decides to go against the local protocol and to request a test for a young patient that was treated for atypical pneumonia and was not getting better. And we know the rest. In the previous days, we were thinking that we were finding and contact tracing and testing people that were coming from China and so on. So I think we thought that we had something like 4 or 5 cases in total in the country. That moment is a big cold shower for us because the risk criteria changes overnight. We start to test a lot of patients in intensive care in the hospital. Basically, we realized that with thousands of patients, and as you know, a secondary transmission that has been basically undetected for weeks. In about 24, 48 hours, we got together and put a plan together with the network of ICUs in the area. And I have to say, Antonio Pesenti and Giacomo Grasselli, you will see them around the Congress these days, have been really instrumental in coordinating how to put the resources together. To put things in perspective of numbers of where we started, on the 20th of February, we had about 50 ICU beds in our scouting that were free in the region, over about 900 level 3 ICU beds. In Italy, you can get a bit of level 2 care also in other parts of the hospital, intermediate care and so on. But basically, for ventilating patients, that was the pool of beds that we had. So really not much. And immediately we started to count how these admissions were coming to our intensive care unit. So it was clear, unfortunately very soon, that it was 11, 12, 14. It was not just linear, we was probably going to an exponential phase. That's when we started to ask the government to put restrictive measurements in place. A few days before, actually, we started, but finally on the 5th of April, it was the first lockdown in any country in the region and then in Italy. And I think in those days, probably one of the things that in retrospect, I think we did well with the group of clinicians there was actually realizing that we were not prepared. We didn't we underestimated before, but we didn't downplay what was happening. And during those days, I think Manu was talking about this information before, and we've seen it throughout all the pandemic. But at the beginning, there was really a lot of opinion leaders that were coming up on TV and saying, this is just a flu, don't worry, it's just a bad cluster. It will just be a few patients and everything will come back to normal. And that's a normal reaction in a crisis. That's what we are all tempted to do. You tend to downplay, say, let's wait a bit. And so the reality, what you need in those moments is to act with urgency, to be very transparent and say, we hope that we'll get better, but the numbers are not saying that. And really to communicate transparently as much as we can. That was the reason why with Joseph Keseshoglu, a friend, and he was the president of the society at the time, I was the president-elect, I called him, I think, immediately on the first, second day. And as a background, the week before, we were together in Orlando at the Society of Critical Care Medicine. And I remember speaking with many colleagues that I'm seeing here in these days, and everyone was looking at Wuhan, where the crisis has been going on for probably a couple of months at the time, since November. And we all thought, if there is an outbreak, we will have to do something. But I knew that no one was really prepared to put an action plan in place. So this was a letter that was circulated to all our network and also to newspapers and so And basically it was a very simple message showing how poorly prepared we were and what we were trying to do during those days, and sending a message basically of getting ready, and getting ready through trying to decrease the transmission in the community if it was occurring, and also thinking about surge capacity, because as we know, the story everywhere in the world was about getting ready to surge. Education, which is the topic of my talk today, I think has been very important, not just at global level, but also at a local level as well. I had about 48 hours where I was lucky not to have patients coming to my A&E, and I was not requested yet to take a patient. And those 48 hours were golden hours for my team. I got, in the middle of the night, I called the university and say, can I bring the simulation team in situ while we were setting up an ICU? And we trained basically the first 80 healthcare workers in donning and doffing and intubating and proning with all the gear. These are things that you do even before a pandemic, but you're never ready really if you don't rehearse. And we were doing random drills during the first 48 hours. I have to say that was very important to create a sense of feeling of a team, to be ready for something that could come, and also to give a sense of psychological safety around, and safety in general. So we even put a safety officer to make sure that when you were exhausted and coming out of the shift, you were having someone helping you to do the doffing procedures, which, as you know, is the most dangerous one. And at the beginning, we just didn't have enough PPEs to go and get change and rest, so we were drinking, eating, going in the gear, and coming out after 8 hours. So another thing that we tried to do was also putting together clinicians and scientists around the world. You may have seen this. This was a marathon that we did a month from the beginning of the crisis. Within 5 days of the crisis, we organized the first webinar with Bingdu from China. And again, that was streamed worldwide, free for everyone, so that we could share all the information that was coming through. And I think there was a great sense of solidarity and unity in those moments. And I think everyone wanted to help, everyone wanted to share information. And the great thing was also that no one was scared of showing the weaknesses. You wanted to show what your weaknesses were so that others could prepare better. And after the first wave, we all hoped that it was the last one, but as we know, it was not the last one. We started to receive also requests from European institutions to help. They saw some of the work that we were doing, and so they came to us as a society and said, look, we're buying ventilators, we're buying drugs, can you check with us if this is okay? And what we told them is that it's great that you're storing this stuff, especially PPEs at the beginning were really lacking, even if I'm not sure if they were lacking. I think everyone was taking something for themselves, even they were not needing it. We said, you probably need a blueprint to make sure that you distribute what is needed in the future. It's great that you're buying more ventilators, but the reality, the bottleneck is not going to be the ventilator. The bottleneck is the fact that we cannot train more ICU specialists or more ICU nurses just in a few months or in a few weeks. But what we can do is giving some basic skills, at least in those hospitals where they didn't have the time to prepare their training, so that these people that are deployed from elective surgery and other elective services that maybe are stopped in case of a second wave could feel better, could feel less stressed about joining the team, would have some skills that the ICU team can get. And I have to say, the European Commission was very receptive to this. And within a week, they told us, okay, we discussed internally, and we are going to support a training, but you need to organize it and deliver it, and we want it ready basically by October, and this was August. So in 3 weeks, we got 70 experts together. In my hospital, we built an ICU in 12 weeks from April to July, and that ICU was not used. It was supposed to be used for COVID in case of a second wave. And we had a window of about 3 weeks to go there and film and to create also virtual reality movies to train people then in the future. I have a small video about this that I'm going to show you in a second if it starts. The audio is not working, I'm afraid. It was working on the... Is there any sound? Well, you can see some images. They will give you some ideas of what we were doing. These are all part of the training that we filmed. The reason why we went also for virtual reality, and virtual reality is not the biggest part of the training. A lot of the training is done online, and there are also toolkits that you can use locally. Indeed, we had the support of about 2,400 trainers across Europe that they got the material and then they trained people, and we train about 17,000 people with this training. The reason to do for virtual reality was the fact that we realized that after you've done some online training or some face-to-face training, as you know, you want to see how you're proning a patient, you want to see how you're intubating a patient, but that's very time-consuming. You may not have the time or the right time to go and find that procedure to be done in that moment. So we thought if we use virtual reality, you will basically be immersed in an ICU team and you will see the different components of this. So there is a part of that that basically was an idea to maximize the time in order to be exposed to something that you will see. It will not be the first time that you did that. We published the results of this training recently on intensive care medicine, and we did 2 pathways. There was a common track and then 2 tracks, one for doctors and one for nurses. We have a lot of countries that went for this training. If you look at an index per population, some countries they use it more than others. And we were also able to show that there was an increasing knowledge before and after the training. But I have to say, for me, the nicest thing was to receive a lot of feedback from trainers and from trainees, from local teams saying basically, I feel so much better after having done this and then going to the intensive care to go and help. And I would say this is probably something that we didn't measure as an outcome, but that we hope that it made a difference also in terms of stress and maybe post-traumatic stress disorders and so on after that. I'm going to conclude just to say that really this is not just the only teaching and training. Training has been done everywhere. I really would like to praise also the WHO for their leadership. I am part of this group of clinicians that review the evidence, and we've been reviewing evidence for the last 2 years. And it's been amazing to see how scientists and researchers have been sharing data even before the study was published, just to get the data together, to use great system to review the evidence and to put practical recommendations at the bedside. So I think we will remember these years as difficult years, but also amazing years of solidarity, unity, and now through research and training education, we try to save lives. Thank you.
So we have time for 1 or 2 questions from the audience, if anybody does. It's hard to see. I can start. So one of the things that I think is amazing is what you've been able to accomplish in this short period of time. But I do worry that, like many things with COVID, and the prior speaker had mentioned about the walls coming back up between our silos, that all these educational initiatives may die with COVID dying down. And I'm curious, given that you've been able to disseminate information so quickly and it's received such positive regards, is there an intention, or do you think there's value in continuing to share education in the way that you guys have already demonstrated can be done quickly, but more longitudinally?
So, yes, I think there is, and I think you just have to do it. This training at the beginning was limited only to European countries because it was funded by the European Commission. And we didn't feel very comfortable in working just with this framework, for instance. So in parallel, we set up another training, which I didn't show today, which was called ALIVE. ALIVE is a fund that we use to do teaching and training and promote practices around intensive care in low and middle income countries. And so we did some COVID-19 training also for that. And that was free for everyone. That has been done, I think, by 2,000 people around the world. And now we're partnering with some colleagues in Vietnam to translate it, for instance, in Vietnamese. So we have a global intensive care group in the European Society since last year. And basically, the idea is to try and help wherever is needed with intensive care. And the WHO has seen what we have done, and we are partnered with them now. And so this training program will be open, C19 space, the one that you saw, also, and translated in different languages as well. And we kept it open as much as we could. There are some costs, but we're trying to absorb it. And I have to say, it's been great to see how members have believed in this. Because, you know, we are a society of individual members. We need membership to be able to sustain also what we do. And we opened this also to non-members. And that was a kind of a risk if you want. But actually, we're very pleased to see that our membership actually agreed on this, and they're very happy to be part of this effort and to carry on doing so. So next week, we will have the first marathon to start a new series of webinars. We call them Alive Solidarity webinars. We've done the first two last week, speaking with colleagues from Ukraine. We have spoken with them and said, what can we do for you? The first thing that they ask you is, of course, if we can find a way to bring supplies and aids at the hospital. And that's very frustrating because everyone is trying to help, but as you know, the humanitarian corridors are not open yet. But interesting, similar to COVID, they told us that a lot of the activity in the hospital has been stopped. They have a lot of people coming to their teams, and they need training, and they don't have the time to train them. So we've done the first two webinars, and we told them, but you choose the topics. You shouldn't be us telling you what you should learn. You tell us what we can do. So one was on triage and intensive care. One was on hypothermia, because you're getting huge amount of casualties from the field on this. And now basically we're starting this new series, again, of webinars. It will not just be about the war that is ongoing now, but in general about humanitarian crisis, and now we can help really with teaching worldwide.
Thanks very much, Maurizio, for a wonderful talk. It's my pleasure to introduce our next speaker, Dr. Fernando Armastar. He's from the Hospital Universitario in Badalona, Spain, and he's going to speak to us about how the use of biomarkers helped in the diagnosis of bacterial co-infections. Welcome, Dr. Armastar.
Thank you. Good morning. I would like to thank the organization for the kind invitation, allowing me to speak on the important subject of how the use of biomarkers helped in the diagnosis of bacterial co-infection, focusing in critical care patients with COVID-19. Yes. This is my disclosure. The agenda to be discussed will be bacterial co-infection in ICU patient with influenza, bacterial co-infection in ICU patient with COVID-19, the use of biomarkers in the diagnosis of bacterial co-infection in ICU patient with COVID-19, and finally, take-home messages. What about bacterial co-infection in ICU patient with influenza? In this study, 17.5% presented bacterial co-infection. Patients with bacterial co-infection were older and presented higher scores compared with patients without bacterial co-infection. Pneumococcus was the most prevalent bacteria. The next prevalent bacteria were Pseudomonas and Staphylococcus aureus. I note that Aspergillus was the second most prevalent pathogen. Patients with bacterial co-infection required invasive mechanical ventilation and vasopressor drugs more frequently than those without community-acquired respiratory co-infection. The length of ICU stay was 3 days longer in patients with bacterial co-infection, 11 days versus 8 days. What about bacterial co-infection in patients with COVID-19? In this meta-analysis, bacterial co-infection was 3.5% in general population. But in ICU patients, this number reached 8.1%. Similar results were found by different studies. Here we can see two studies. In both the studies, bacterial co-infection was 8%. In this trial, we can see the ICU mortality predictors. Age, yes, D-dimer, CRP, age, were associated with mortality, but bacterial co-infection wasn't associated with mortality. So it's not certain that bacterial co-infection with patient with COVID-19 is associated with mortality. But we know that bacterial co-infection in patients with COVID-19 is associated with more need for ICU admission, longer hospital length of stay, and higher consumption of medical resources. The guidelines on surviving sepsis concerning the management of critical care patients suggest the use of antibiotic in patients under mechanical ventilation and failure respiratory. And in this meta-analysis about antibiotic prescription in patients with COVID-19, ICU patients, antibiotic prescription in ICU patients was 86.4%. And we know that antibiotic overuse is associated with antimicrobial resistance. So there are two options. Number one, antibiotic for all critically ill patients with COVID-19 pneumonia, because they are very critically ill and any co-infection may increase the likelihood of death. Or number two, antibiotics only for critically ill patients with COVID-19 pneumonia who present criteria for bacterial infection, because overuse of antibiotic can, among other things, increase bacterial resistance of antibiotic. So, can biomarkers be useful? We know there are many biomarkers described, more than 170 sepsis biomarkers described, like cytokines, cell surface, receptors, complement, coagulation factors, acute phase reactant, but only CRP and PCT are routinely used in medical practice. In this trial, the use of procalcitonin had impact in antibiotics days, in antibiotics of days without, in number of days without antibiotics. And in this trial, the procalcitonin levels in ICU patients with influenza, we can see that male gender, yes, Apache-2 score, SOFA score, obesity, shock, acute renal injury, and PCT were associated with community-acquired respiratory infections. As we can see, PCT value was 0.5 in patients without bacterial co-infection and 2.4 in patients with community-acquired respiratory co-infection. In this study, we can see this algorithm. The procalcitonin value below 0.29 had a negative predictive value of 91.6%. And if the patient didn't present shock, the negative predictive value was 94.5%. In this study, in this meta-analysis, high procalcitonin level was associated with mortality, as you can see. And in this study, high procalcitonin level was associated with severe coronavirus disease. And this is the last study that I'm going to show you. This study in patients, in ICU patients with coronavirus, the, the hypertension, the diabetes mellitus, the chronic obstructive pulmonary disease, hematological disease, Apache 2 score, SOFA score, CRP, and procalcitonin were associated with bacterial co-infection after univariate analysis. However, when logistic regression analysis was performed, only hematological disease was associated with bacterial co-infection. This study, we can see the ICU mortality predictors: age, ischemic heart disease, immunosuppression, hematological disease, Apache 2 score, hypoxemia, PCT, dimer-D, invasive mechanical ventilation, acute renal injury, myocardial dysfunction, and ventilator-associated pneumonia were associated with mortality. But bacterial infection wasn't associated with mortality. In this study, PCT value below 0.3 had a negative predictive value of 91.1%. The take-home messages are bacterial co-infection in critically ill patients with COVID-19 is not as frequent as in patients with influenza. We need to install a careful antibiotic stewardship that avoids unnecessary treatment that may lead an increase in infection by multi-resistant bacteria. Bacterial co-infection in patients with COVID-19 worsened outcome and increased ICU stay. And finally, although we don't have a biomarker to make a diagnosis of bacterial co-infection, a low procalcitonin value is useful to support the absence of bacterial co-infection. I would like to send the COVID-19 semi-suge attack working group and my infection team. Thank you.
Thank you very much, Dr. Armistar, for a wonderful talk. And the presentation is now open for questions. Are there any questions from the audience? Maybe I'll ask you a question, Dr. Armistar. Practically speaking, you know, were the clinicians, do you feel that the clinicians are going to be influenced a lot at the bedside by using CRP and PCT to risk stratify in the context of everything that was going on? That's just a practical question. Did you see that clinicians were motivated to do that, or really responding, understanding the principles of antimicrobial stewardship, but really responding in a crisis in an emotional way to wanting to prescribe antimicrobials just in case?
In the medical practice, it's very difficult for me to explain to my colleagues about the antibiotic prescription, because the majority of them want to prescribe antibiotic microbial in patients, in critical care patients with COVID-19. So I think that it's necessary to talk with them a lot of time to change this idea that, I don't know with the audience, but I think that many doctors want to prescribe antibiotics all the time. And I think that we need to change this practice.
Yeah, I guess just as a follow-up quick question, you know, maybe speaking very quickly to the challenges of enforcing antimicrobial stewardship principles in the context of a crisis.
could you repeat again, please?
Oh, yeah, for sure. I'm sorry. I was just saying, just a brief comment from you perhaps about how hard it is to observe antimicrobial stewardship in a pandemic.
Yes, again, I think that I need to training in antimicrobial prescription, and I think that we need to see what happened on the first wave, for example, with the antibiotic prescription. I think that this is the moment that think about them.
Thank you.
You're welcome.
Great. Thank you so much. Our next speaker will be Philip Schutz. He joins us from the University of Amsterdam, and today he'll be speaking to us on how to apply the many proposed biomarkers, a nice follow-up to our prior talk.
Thank you very much. Actually, it's the University of Basel in
I'm
Switzerland, but it's not a problem. Thank you very much for your invitation, and I'd like to move on here with talking about biomarkers and how we may use all these biomarkers for our COVID-19 patients. These are my conflict of interests, and I think I'd like to start just by echoing some of the talks we had before. And I think it was very impressive to see how COVID just came in and we didn't know about this disease. But I think here biomarkers really did a great job helping us understand the disease. I think biomarkers gave us a good link to inflammation, to coagulation, to organ dysfunction. And I think through the study of biomarkers, we have learned a lot about the disease, particularly during the first wave and during the first time. So importantly, I think we have learned also through, of course, the clinical evaluation of the patient, but also the biomarkers, that COVID-19 is a disease that can be mild and not do a lot of problems, but then also we can have a second hit and go into a pulmonary phase, and then the hyperinflammation, once this kicks in, then we see that our patients really are in trouble. And I think the biomarkers really mirror these different stages of the disease. So what can biomarkers help us in understanding and managing COVID-19? And I think there's probably like these 4 key points which I would like to briefly touch on. So first, I think it's the pathophysiology. As I mentioned, I think it's important, particularly in the early days, biomarkers helped us to understand what was going on. Second, risk stratification in ED and also in the ICU. I think hospital resource utilization is one of the key points. We didn't have enough beds for the patients, so we had to triage. And so here, of course, understanding the risk is very important. Then also risk stratifications regarding specific drugs. I think this is something we are still struggling with, and I will give you some example how also the biomarkers can lead you in the wrong direction. And then also I would like to make a brief comment on superinfection, as was just done by Dr. Armistar. So when we go back again to the different stages of disease, so I think in the very mild phases, we do not see a lot of biomarker increase. We see maybe a mild lymphopenia, normal blood gas, but then the more severe the disease becomes, the more the host immunity kicks in. We see that these different markers increase. D-dimer, I think, was one of the first ones where we understood D-dimer is very important and also mirrors the high risk of VTE and the derangements in the coagulation system. We have seen all these different inflammatory markers, ferritin, PCT, CRP, as was mentioned before, LDH, and then, of course, we see hypoxia. And then if we see worse, patients getting worse, we also have the different organ biomarkers, troponin, we see BNP, we see the renal, the kidney markers increase, and so on. And so this makes, I think, a lot of sense. And also, I think there has been a lot of progress to understand how these biomarkers are being produced. where they are being produced and how should we read them. So is it coming more from a peripheral inflammation versus is it a pulmonary inflammation? And so the markers also tell us about where we have the problem in our patient. So let's start to look at some of these questions. Risk stratification for disposition. And I think it was very impressive also to see these pictures not only from New York, but also from Italy in the early days. And so I think it was clear from the beginning that we have to understand which patient is at risk. I can remember our first patient with COVID in the hospital. We kept him for about 6 weeks. We wanted to have him a negative PCR test before we would let him out because we didn't know how to handle it. And then with the increasing numbers, of course, we understood you cannot keep all these patients. You have to understand which patient is at risk. And so here we have learned that these inflammatory markers really give us a very high accuracy which patient will progress to most severe disease. There is also, I think, amazing number of studies that have been published on these different biomarkers. So I'll give you just here one example for ferritin, and you see the area under the curve here is very high and shows you that if this marker is up, the risk of this patient deteriorating is just very high. And we also have seen a lot of systematic reviews, meta-analysis with all these studies. So this is another example for the D-dimer test. And you see these are all studies from China, one from Ireland. You see small numbers of patients, but overall you get a very good picture. And I think from these smaller studies, if you put them together, you can realize very quickly, yes, the D-dimer test is a prognostic marker, and if D-dimer is up, this tells you that the patient is in trouble. Also, there have been several groups that have tried to combine different clinical scores, clinical parameters and different biomarkers together. And we have recently done a validation of 4 of these scores: the COL score, the CHOSEN score, the HA2T2 score, and the ANDC score. And you see basically all these scores, they had different parameters which are more vital signs, biomarkers, age, and they were all done in a little bit different patient populations. And of course, the idea is if you combine clinical information and biomarker information from different organ systems together, then you will get more information and your score will be more accurate. And actually in our validation study, we found that the scores did perform pretty well. You see here always the blue line is the one in the lower risk, and you can see for some of the scores, the negative predictive value is actually excellent. So in these, for example, the COL score or this score, you see that none of the patients that was in this low risk group actually progressed to more severe disease. And of course, you can argue that these patients you could send home safely and manage outside of the hospital system. So I think integration of these biomarkers into these scores, I think that's a good way to really get most of the prognostic information for our patients. Now, which of the scores is the best one and we should use in the future? I think this is still unclear, and still we probably need a bit larger studies. Also, there is newer biomarkers. Pro-ADM is one of those that has generated a lot of interest in patients with pneumonia and respiratory infection, because it's one of the main markers that is implicated in inflammation. And of course, COVID is an inflammatory problem. And so also for pro-ADM, there were some studies by our group, but also by other groups showing that it has an excellent negative predictive value. And so again, here you can see in patients with non-elevation of pro-ADM, you had an excellent negative predictive value, and these patients would not progress, while the ones with an increased level, you can see that a lot of these patients would progress. And also there is other prognostic markers here. I just want to mention maybe SUPAR, where we have seen some recent papers also demonstrating that SUPAR has prognostic ability in these patients. So certainly risk stratification, I think with biomarkers, this is one of the fields where biomarkers are very strong. I think combination of markers in a score is probably the most rational way to use it. So how about now guiding therapeutic decisions about coagulation? And here there are several consensus statements and guidelines, and I think it's pretty clear that the D-dimer test is an excellent test that tells us about the risk of thrombosis, the risk of pulmonary embolism, and is one of the hallmarks also for COVID. But this is, I think, here a story where we can also learn for the future that we have to do the research very carefully, because it's not as simple as it may appear. It's very clear D-dimer is a prognostic marker. It's patients with high D-dimer have a higher risk to die, a higher risk for PE, a higher risk for VTE. So you would say, okay, we need to give these patients higher amounts of coagulation, right? You would need to do a full coagulation in these patients to protect them. But here comes the problem. This is exactly what was not true. And we do have several studies looking at coagulation. And of course, this is one of the things we do in patients, but it's the other way around. So it's not the high-risk patients in ICU that actually, with the very high D-dimer, who actually benefit from the high dose of heparin, but it's the low-risk patients that do benefit. And I think this is something that we all would never have imagined when we saw these data. But I think it is now pretty clear that here the D-dimer test could bring you to the wrong conclusion if you wouldn't do the research correctly. And there is a nice editorial trying to come up with an explanation, well, why is the high-dose heparin not working as good in the high-risk patients as in the low-risk patients? And I think we don't know really, but maybe we are too late in these patients, and maybe if we use it earlier, then we can really prevent it. But once we are too late on, then the risk of bleeding and complications is just higher than the potential benefit we have from these drugs. Of course, there's other drugs, anti-inflammatory treatments, and also here the biomarkers are helpful or could be helpful. And I think the best drug we have so far is dexamethasone to blunt the inflammation. And so I think here we really have a beautiful biomarker, a biomarker that is also very cheap. And this biomarker is called oxygen need. So if you have a patient and this patient needs oxygen, then you know this drug will help the patient. But if your patient does not need any oxygen, you can see then there is no effect, and you're rather hurting your patient than you're actually helping the patient. So I think this is one of the examples where really a biomarker, arterial blood gas analysis or oxygen need gives you an excellent therapeutic information about the use of a drug. Well, how about all the other anti-inflammatory drugs that we have? And you know, we have tocilizumab is one of the big players now, although the studies were not so clear at first, but now we do have several studies, and if we look at the overall picture, then we find that tocilizumab is helping the patient. Now, when you see all these different studies here, and you see there is so much variation in treatment effect, well, then there is maybe one of the explanation could be that there is a problem in our population, and maybe it's not all the populations that are benefiting from the drug. And so if we think it's not all the patients, then of course we could say maybe we should have a biomarker telling us which patients are benefiting from the drug. So which biomarkers would you like for tocilizumab? And I think we would all agree that we would like to see IL-6 here. We would like to see all these trials stratified for IL-6 because this is a very close link to tocilizumab, of course. Unfortunately, we did not have really the measurements in the trials. One of the larger trials, they had a subgroup analysis done with C-reactive protein, which is closely related to IL-6, and they reported that there was no effect modification if you stratify by C-reactive protein. So in this case, I don't think that we really know whether IL-6 or CRP can help us to select patients that would more or less benefit from this treatment. And of course, most patients or all patients that were included in the trials were inflammatory patients, and so all these systems were upregulated And so a patient with no CRP or no IL-6 expression who is not inflamed would not benefit from the drug. And then also for these newer drugs, anakinra, we also have, I think, excellent biomarkers, and I think it would be very important for the future then, when we see publications of these drugs, also to see whether stratification by the underlying biomarker helps us to better stratify which patient do or do not benefit. So let me just make a last comment on my fourth point here, superinfection, because we have heard about superinfection just before from Dr. Arme Star. And I agree with him that there is some interesting data. So this is one study done by Dr. Welte's group from Germany. And you see here, they also compared patients with COVID, with secondary infection or no secondary infection. And it's pretty clear that the PCT level, the peak level is much higher in these patients. So it's about a 30-fold increase in the patient with a COVID infection and a superinfection. So I think this is pretty strong data. And so we have also seen a lot of publications that have used PCT stewardship in patients. So I think the one thing that researchers have done is to find infections in patients with high PCT, and the other thing is to exclude infection in a patient with a low PCT level. So in our hospital, for example, in the early days of COVID, because we were unsure why these patients have these infiltrates and get worse, and so we used a lot of antibiotics in this time because we were just unsure. And so I think here a low PCT level is also reassuring that we just have a COVID pneumonitis and we do not see necessarily co-infection. And so there are several such studies that have used algorithms, and I think we will see more of that and understand how this really helps us. Just one word of caution for the biomarkers. Also the drugs can influence the biomarkers, and there has been this research paper looking at dexamethasone and also tocilizumab. Particularly tocilizumab seems to be very strong in reducing the biomarker levels. And so I think this is one of the caveats when we use biomarkers to monitor the patients and we use these drugs. We have to understand that also the drugs have a direct effect on the biomarker levels, and so it not necessarily mean the patient is improving, there is no more trouble, but it just may mean that the drug is working, but the patient may at a second point still can get worse. So I think this is one of the things we need to keep in mind. So how can biomarkers really now change the way we treat COVID-19? And so I would say, first of all, the pathophysiological understanding of disease. I think here biomarkers did a great job. And I think we learned a lot from biomarkers, and we learned about COVID. Second, I think risk stratification. I think here also the goal is accomplished. I think we can use biomarkers. We don't know which are the ones, the best ones. Is it a score? Is it a single biomarker? I think here this is still open for discussion. Now, risk stratification for specific drugs, I think there is for fortecortin, we know that oxygen is an excellent marker, but for all the other drugs, I think we are not there. And as I've shown you with the D-dimer test, I think we have to be very careful how to use these tests for our patients. And then also for differentiating bacterial superinfection from disease progression, I think here antibiotic stewardship, we do see some interesting data around PCT. We haven't seen the big randomized data, but I think what we have seen so far is pretty promising, and I know a lot of colleagues that are using it in their hospitals and are trying to reduce antibiotics in this way. And with that, I'd like to close, and thank you for your attention.
Thank you so much. So again, the floor is open for questions from the audience, if anyone has any. This is great. I get to, oh, is there a question up there? Great. I keep getting to be in the opportunity to ask. Wonderful.
Hello. Yeah, Dr. Kulkarni, I'm a consultant in intensive care coming from UK. Clinically, you get these patients who look very unwell. They've got temperature, they're in multi-organ failure, who are on inotropes, but then they've had tocilizumab and the CRP is not raised. Even the procalcitonin is not quite convincing. So how do you hold yourself back from starting antibiotics? Because what strategy do you follow?
I think that's a good question. I think sometimes you have this mismatch of a patient and the biomarker, and I think this is always a challenging situation. So if I see a patient that is deteriorating and he doesn't look well, as you mentioned, but the biomarkers are down, I certainly would also look for other causes. So could he have, I don't know, a myocardial infarction? Could it be a PE? Could it be another cause, right? If PCT is up, I think then the chances of a bacterial superinfection are just much increased. I think in the end, it remains a clinical decision based on your assessment of the patient, and the biomarker gives you one piece of information, but you cannot just listen to the biomarker. You need to treat, in the end, the patient. And so I think it's just, if you have a mismatch, you just have to be very careful and go back to the patient. But in the end, I mean, sometimes you just have to treat the patient anyway, even if the biomarker looks in the wrong direction, in the other direction, because we know biomarkers are not 100% right. So in the end, I think this is, a skill of a good physician to integrate all this information and make his decision call.
Thank you.
All right, thank you very much for an excellent talk, Dr. Schutz. So we're right on time, and maybe we'll just continue to the next group of speakers. It's my pleasure to introduce Dr. Eloisa Garcia Velazquez from the Kennedy Hospital Group in Ecuador. And she's going to talk to us today about how to improve nutritional support. Dr. Garcia Velazquez, thank you.
Thank you very much. Good morning, everyone. So we're going to talk about how to improve nutritional support after COVID-19 and what we have learned so far. So those are my disclosures. And of course, in Ecuador, what happened is in February 2020, we have our first patient, and from that we had a terrible first wave. And you can see in the upper right hand here, those are the cases so far until February of today and the death so far in Ecuador. So what about the COVID-19 population? Well, we heard so much at the beginning, I think, about what kind of patients we were going to see in the ICU, who were going to be hospitalized, and we heard about the elderly patients, so those were going to be like the more prone to be more in the ICU, but we saw really soon that it wasn't like that we had polymorbid patients, obese, malnourished, we had cancer patients, every patient possible. But of course, for us in nutrition, we know that malnourished patients, it's going forward. I don't know how to go back. It went forward. No, I don't know how to go back. Go back. I'm sorry. I don't know how to go back. I just put it there. It worked for you. One more. Okay, thank you. Okay, sorry for that. And the malnourished patients always have a negative impact of survival, even from the disease that they had. So, well, this is a patient that was 2 months in our ICU. But as we know, the ICU patients that had COVID had prolonged ICU stays. That's only an independent cause, for malnutrition. And as we know, all the patients are going to lose function and muscle mass, and that's going to be really important because if this patient has a long stay, now we know they have a long recovery afterwards. Okay, so why does this happen? Well, we have the acute phase, we have a hypercatabolism, and we have rising energy debt. Why? Because these patients, especially in the first wave, they were staying so much at home for so many times. They were having a lot of symptoms at home, maybe not eating at home, and not getting the attention that they need because we were in a healthcare crisis. So maybe the emergency room was full. I didn't get to go to the ICU. And even the healthcare workers, me included, got infected. So that led to the loss of lean body mass for our patients. So what about nutrition? Nutrition is not only a prescription, it's a therapeutic approach. So of course, we have a new ICU patient. We need to do the screening and assessment for that patient. We need to know and really assess what patient is at nutrition risk, and we need to design our plan. What are we trying to do and where we want to go? Is what time do we need to start the nutrition? It's going to be EN, PRN, oral nutrition, when, how much, and of course we need to monitor our patient, how we're going to get to that target, and what kinds of complications can they present during their hospitalization. And I put that little sentence in the bottom, don't forget to follow our patient, because we usually do ICU, and we're with the patient on top, but what happens when they go to the ward, right? We don't need to lose that patient. So what we need to search is to evaluate the nutritional status with direct or indirect interview. Maybe at first when the COVID-19 hit, we had a lot of indirect interviews because the families weren't allowed in. We have to search for comorbidities, gastrointestinal symptoms. It was really discarded at first that COVID could have gastrointestinal symptoms. And what is the importance of that is because it can lead to weight loss, reduced food intake, loss of function. If our patient is telling us, well, I can't go to work anymore, I can't get out of bed, I can't get my bath on my own, that means that they're losing muscle. What about mental health? That's really important because when COVID-19 hit, I think it's a life-changing situation. It was a life-changing situation. So that can take a toll in depression or anxiety, and that can change a nutritional status for our patients. And another really important question is to ask our patients when did their symptoms they think they started, because that can really help us link when maybe the weight loss started also, or the loss of lean body mass. So what about the dose of our patients? Are all the same? If we do indirect calorimetry, or we do the equations, or what about the 20, 25 kcals that ESPEN or ASPEN are telling us? Well, they are not all the same. Of course, if we have indirect calorimetry that we don't have, I don't have it in my country, but if we can do that, we need to do it. Why? This is a study done in the States, but it has been done here in Europe as well, when they tell us that what about the energy expenditure of our patients. For example, there is, I'm sorry, here is the indirect calorimetry line from our patients, and you can see there is a progressive hypermetabolism peaking at week 3. And what about what ASPEN tells us to do is here, the upper end, the lower end for ASPEN is here. This is the Penn State equation, the Harris-Benedict, and the MSG equation. So they are not exact for our patients. So what we're aiming for right now with nutrition is to have more exact numbers, because, for example, if I tell you, we just talk about antibiotics, for example. If I tell you, oh, we're going to give the patient just half a dose, who's going to accept that? I don't think anyone is going to accept or think that's right. But with nutrition, we allow ourselves to do that. So we need to think what's going to happen to those patients. And we can see here also the obese patients, or I'm sorry, here. The obese patients, these lines, the green ones, are what ASPEN tell us, the numbers that we need to do, and these are the equations. So they are really far. So if we have indirect calorimetry, we should definitely do it. So well, I set my target, I did my assessment for my patient, and after that we need to think how we're going to give my patient nutrition. Is it going to be EN, PN? Well, as we know, EN is the first choice that we have, and we need to initiate it as soon as possible. Of course, there are many prone patients. We need to know that it's well tolerated, and of course we need to follow our local protocol. In the guidelines, it's stated very clearly that we need protocols, but not only that, because protocols are like guidelines of things that we need to do, but it's really correct to have somebody of the team that is a nutritionist, a dietitian, a doctor that is full-time dedicated to nutrition to have a real impact, because we can also need peripheral PN nutrition, for example, or we can have supplemental PN if the patient needs that also. So this is a study, this is done before COVID-19 with non-invasive ventilation. What happened with non-invasive ventilation that we really use it in COVID-19? What happened is that, for example, of 1,000 patients, more than half didn't get anything to eat for more than 3 days. Okay, so we're just making the energy depth really, really high, and they're usually inadequate energy provisions with these kinds of ventilation. So what Dr. Piersinger asked was to eat or to breathe, what we need to do, and of course the answer is both. What happened with the NG tubes with these kinds of ventilation systems, if they can be not so effective because you're breaking, like there could be an entrance, so maybe there's not going to be really effective, or they're wondering if there's a stomach dilatation and affect the diaphragmatic function. What we need to know with these patients, if they need this kind of ventilation, this is not a patient that we're going to go send home tomorrow, right? So we need to really think, what are we going to do about the nutrition? If we can put an NG tube, there's always a solution. Well, maybe we can put peripheral PN or total PN. We always need to think that the patient needs their calories, of course, adjusted to the clinical situation that the patient has. We do not need to do overfeeding. So what Espen said, and here we have this really flow of the setting, the ward, the ICU, what can we do afterward. But what they really said is we need to start nutritional support as soon as possible, and we do not need to wait because the energy depth is only going to get higher, and we have more patients to rehabilitate afterwards. And that's a problem right now, right? Because we're seeing more long COVID. So what about the intubation period? We need to start EN as soon as possible. It's well tolerated in prone position, and we can consider PN when EN can cover all the requirements, especially after day number 4. And what about the post-intubation period? We need to really consider dysphagia, really evaluate our patients. We do not have to remove the end tube really faster. We need really to know that a patient can eat. And what can happen also is that maybe the patient needs the non-invasive ventilation. And it has been seen, and in many studies it has been shown, that they can only eat 550 calories. There is more energy depth when patients are eating because it's really hard to quantify how much they're eating. But most patients, when they are post-intubation, they will like more things like they are liquid, they are soft, they're not going to eat like they used to, right? So if we need to make our patients stay in EN or PN to cover nutritional requirements, and we need to follow our patients. A key point in nutritional support is always to monitor, and we need to search for ICU weakness also, because muscle is related to weakness and to function and to quality of life after having COVID-19. So what the pandemic also taught us is that we need to have protocols, especially in nutrition, because at first dietitians and nutritionists maybe weren't allowed in the area. So who was going to do all of these jobs that I just mentioned that we need to do? So it's really important that we need protocols in the area. That doesn't mean that we don't need the nutritionist. We do, because we always need an expert to have tailored nutrition, but it's something that I think we really need to learn, that we need to have protocols. I know this is in Spanish. This is my own protocol in Ecuador. This is what I did when we first started. And what I put here, because we don't have indirect calorimetry, like I told you, I put how you can do the first step of assess the patient, which one was at risk, and here to mind, please, if the patient was getting dextrose or propofol, and do the glycemic control. And in here, what I did was I put like the speed of the nutrition and how many kcal and protein the patient was getting. And I raised the name of the product, of course, but I put it with every product, so no one had to think. They only need to search what the patient needed. And we had that because I think we need to have, of course, we have the international guidelines, but we need to put them in like our ICUs, and we know what kinds staff do we have. So the last question will be nutritional status and COVID. It was an opportunity for lasting change. I think it was, because we can see the value of nutrition during the disease. We have a lot of muscle mass weakness. I don't know, I have been doing this ICU nutrition for 5 years now, and I haven't had a disease that the patient lost so much muscle in so much little time, especially if we don't act in time. And I think this gives us a really good value of what ICU nutrition needs, and it needs to be more exact, and there's always going to be a need for a dietitian, a nutritionist, a team that works with these patients. And finally, well, this is my team in Ecuador, and of course, nutritional therapy is a multidisciplinary therapy. Thank you very much.
Thank you very much, Dr. Garcia Velazquez, for a great talk. And are there any questions from the audience?
Thank you very much, Michael Cazar from Leuven. A very nice overview of the complexity of the feeding that we see also in our units. I have just one comment, no, two. First, I wouldn't worry about not having an indirect calorimeter, because in fact the likeliness of it improving the outcome of the patients is still very doubtable. So I think you better invest money in other things. And the second comment is that for the early part of the feeding, until now, we don't know whether the high-risk patients need more or less feeding. So it's important to assess nutritional status and the nutritional risk, but it's difficult to know what to do with it, at least in the first week in ICU.
Yeah. Thank you for your question. Well, we don't have indirect calorimetry, and we work every day. We can do it. I'm sure we can do that if we have a good team that can assess the patients and work with the doctors, because we can see, like you said, how much their clinical situation is more bad. For those patients that are really in the first stages, what we do, and of course, is we feed them really slowly to see what can happen. And those are actually what I think we need to do, because we have the guidelines that say 10 to 20, and I think that is the value, that you need to have somebody that knows what they're doing. Because if I get a guideline and it says 20 kcals per body weight, somebody can do that when we know we can't start so high. So we really need to start real slow, because I also think, and I have always think, that the body is really smart. There's a reason why the patient don't want to eat, right? So of course we need to start really, really slow those days. We need to try to get to target, but we don't need to do it faster. We don't need to do it in an irresponsible way. We need to do it the right way.
Thank you.
Thank you so much.
Thank you very much.
Our next speaker will be Wesley Ely. He's joining us from Vanderbilt University in the United States, and he'll be speaking with us on how to better prevent and manage delirium.
First, I want to congratulate Eloisa Garcia Velazquez for a beautiful talk. And Eloisa, I wish we could clone you and have you in all of our ICUs around the world. You're a true leader in this area. You spoke so beautifully about, alarmingly, about the amount of body mass loss, which we know is driven by immobilization, which is driven by delirium. And these two encircling disasters for COVID patients, ongoing delirium, ongoing immobilization, are begetting what I would predict or surmise to be the worst escalation of post-intensive care syndrome that we've seen in the past 2 decades. We have got thousands and thousands of patients accruing an immense amount of disease, neck up, acquired dementia, neck down, muscle and nerve disease, ICU acquired weakness, which one of our chairpersons today, Margaret Herridge, has pioneered and taught us about. And so what I'm going to do today is take you through, using the power of human story and data, what I think is happening with delirium, which has been what I've been asked to teach about today and talk to you about. And I'd love to learn from you as well, whatever you propose as added teaching points to what I share. I'm going to read to you, using the power of human story, from this book of narrative nonfiction, which I published last year. There's no profits coming to me. Every penny from this book goes back to COVID survivors, actually. And in this book, every deep drawn breath, I call it EDDB, every deep drawn breath. The title comes from Steinbeck's East of Eden. I begin with an author note that talks about the difference between what we're trying to do in providing good care and what we're actually doing, which is oftentimes not providing good care. And I think that many times we try to do the right thing in the ICU and don't. So the first couple of paragraphs. Many people believe medicine is grounded in benevolence, that is, wishing good. It's more than that. The target principle of medicine must be a higher standard, beneficence, doing good. This breeds trust between my patient and me, which is the cornerstone of my art and practice. In return for her trust, I promise always to try to help her and never harm her. Every time I step into the hospital, I remind myself of the enormity of this promise, this covenant. Early in my career, I strayed, not intentionally, but out of a desire to control every medical circumstance. I didn't listen well enough. Our greatest treasure is found in deep, real communication with each other. When this is nurtured, especially in times of suffering, two people can establish something of almost mystical quality, a reciprocal connection that brings us to a place of charity and empathy that crosses cultural, social, and racial boundaries. Without such communication, we remain miles apart. And I begin with that because I think that we have been without that communication during COVID. We take our patients, we say to ourselves that their lung disease is so bad that we have to put them on inverse ratio, paralysis, proning, and we deeply sedate them so that if it was an ocean, the patient would not be near the surface of the water, would not be 5, 10, 20 feet down, but would be 100 or 200 feet down at the bottom of the ocean where we can't see them. There's no communication. They are immensely out of touch with us, and we cannot see the whole person, all in the name of helping the lungs. Well, my first point is that the human being is more than a pair of lungs. And the answer to what we need to do about the brain, which is discarded during this period of time in the ICU when we are attempting benevolence but not achieving beneficence, is we need to see the entire person. So the first patient that I ever saw as an intern that had post-intensive care syndrome was Teresa Martin. Her mother, after a month in the ICU stay, brought her back and asked me, why can't she bend her arms at the elbows or move her shoulders? Her mom looked drained, more tired even than when she'd visited her daughter in the hospital. We ran through a litany of other problems that Teresa was having. She couldn't swallow properly, or sleep, or go to the bathroom alone. She couldn't shower or dress herself. She could walk only a few steps at a time, and stairs were impossible. The idea of returning to her old job was exhausting. The list of ailments was dizzying, and I had no immediate answers or solutions for any of it, even less of an understanding of where the problems were coming from. This was 1989, by the way. So I did what I knew how to do. I ordered blood work and chest x-rays. The x-rays, the labs didn't show anything alarming, but the x-ray images of her arms and legs revealed large calcium deposits in her elbows, shoulders, and knees. Teresa had heterotopic ossification, a condition in which bone develops where it shouldn't due to extreme inflammation and prolonged immobilization. It was as if she had rocks growing in her joints. I'd never seen anything like it before, and I didn't know what to think. Teresa didn't react at all when I showed her the disturbing images, but her mother nodded in affirmation, as if she now had permission to talk about her other concerns. She told me Teresa's brain wasn't working properly, that she would now forget things, people's names, that she'd grown afraid. Miss Martin stopped and shifted in her seat. She's a completely different person now. How did Teresa Martin get to that place? The same exact way that all of our COVID patients are getting to that same place. And it's through the path that we just heard about of body loss, immobilization, and delirium. So I'm going to share with you next a single example of a COVID patient with delirium. And I want you to think about yourself at the bedside with a similar patient and how you wouldn't know that this was happening. And we know, by the way, from a data-driven perspective, since I began studying delirium and others did, Joanna Skrobic, et cetera, back in the year 1999-2000, we know that delirium is the principal driver of these four outcomes: death, length of stay, cost of care, and an acquired dementia. So, Kyle nodded. He seemed eager to share. Well, everything was in vivid color. So I'm on a ventilator, and I woke up, and my wife, Katie, was sitting there looking at me, telling me what was going on. I looked over my shoulder, just glanced to the right, and my monitor was there, but behind it, I saw a black jaguar, perched up in the corner in pounce position, moving its tail real slow. I remember getting upset. Katie thought it was about the monitor and being hooked up, and she said, "It's okay, Kyle. It's helping you breathe." But I was thinking, there's an apex predator in the corner. Are we going to pretend that this cat isn't about to pounce on us and tear us apart? By the way, every one of these quotes is a direct quote. I recorded every patient, got all their permissions, and transcribed the recordings. He paused for a moment. I was convinced that if I took my eyes off it, this thing was going to kill us all. My hands were restrained, so I couldn't even defend myself. That went on for about a full day, and everyone thought I was looking at the monitor. And that was upsetting because I was thinking, I'm not the crazy here. You guys don't see this thing? So my patients and your patients are going through this. Each day that they go through this, they have an increased likelihood of dying by 10%, independent of how sick they are. Delirium is an independent predictor of death. And an increased chance of acquired dementia by 35% for each day. What's happening in their brains during this period of delirium? I had a patient named Sarah Beth Miller. She had ARDS. It was garden variety, almost identical to what, for example, Margaret described in all of her papers. And I had her about 2 years afterwards. After the ICU, she got braces, so she couldn't get an MRI for quite a while. She'd never coded. She had no strokes. She never had any profound hypoxemias other than after, in the peri-intubation period. So there was nothing out of the ordinary for this patient. She became the index person that we published about who had pre-IQ testing. And when we gave her her IQ test 2 years later and told her that the answer was 115, which is 15 points above the normal of 100, she freaked out. And we said, Sarah Beth, this is way above normal. And she goes, no, you don't understand. I've always been in the mid-140s. So this woman knew that she had a near genius IQ, and she had dropped down 2 standard deviations. And on MRI, I read you. Since the skull encases all of this in a fixed amount of space, our heads are filled with varying amounts of brain tissue and fluid. As I stared at Sarah Beth's latest MRI, I saw immediately she had a huge loss of an amount of actual tissue. The sulci were much deeper, and the ventricles filled with fluid much larger, having grown to fill the void left by disappearing brain tissue. Millions of brain cells were missing. It was as if tons of rich soil had been removed from a garden, leaving behind puddles of muddy water and a few wilted perennials. 2 areas of her brain showed especially significant degeneration: the hippocampus and the frontal lobes, regions that specialize in memory and executive function. This made sense. She had told us about her forgetfulness and her inability to organize her life. It was sickening to look at, yet I couldn't pull my eyes away. I saw the scan of Sarah Beth's badly damaged brain as a map of her muddled and tangled thinking, visible confirmation of an invisible illness. With Sarah Beth's imaging in hand, I knew I had to find solutions to my questions about why critically ill patients were experiencing so much delirium. I needed to get to the truth. And that's what all of us are trying to do, is to get to the truth. And what we know is we know that for 20 years, we've been studying the causes of delirium and the way to approach it. And we understand that it changes our approach to patients when we have a patient who is delirious. But no one showed us better what it does to our thinking than Dr. Deborah Cook. There's a whole region of this book, a whole section of the book, where I describe Deborah Cook's growing up as a child, what she does in terms of working in a library and choosing to go to medical school. And you know this iconic figure in medicine, Dr. Deborah Cook, who's not at the meeting this time, I don't believe, taught us so much. But I'll never forget picking up the New England Journal and reading her paper about what impaired cognition does to us as thinkers at the bedside. A couple of years earlier, a study by Deborah Cook in the New England Journal of Medicine had grabbed my attention. With her team, Cook had studied 851 patients in Canada who were critically ill on a ventilator and figured out what factors would lead doctors to withdraw support and let someone die. The findings had shocked me. Doctors were 3.5 times more likely to remove life support if they thought the patient had a 1 in 10 chance of ICU survival, 2.5 times more likely if they thought she might end up with severe cognitive impairment, and over 4 times more likely if it was their perception that the patient wouldn't want life support. I knew that a heavily sedated ICU patient, read 100 feet down in the ocean, in a coma, looked dead. And that has absolutely had to play a part in a doctor's thinking. A wide-awake patient with sepsis looked much more alive and well, and therefore likely to survive, than a sedated and comatose patient with sepsis. What she went on to show, of course, was also that we converted a bunch of people to DNR when they were deeply sedated. And I know that I stand guilty here of people probably being in a casket in the ground right now because I withdrew support when I thought they weren't going to live because I had deeply sedated them, turned off the drug, and the residual propofol held on for multiple days, and I thought, well, they're not going to recover. So this is something that we have to reckon with as ICU physicians and realize that when we hold the lung up, and I'm a lung doctor, but when we hold the lung up as the pinnacle of all that we are doing, what we do is discard the rest of the human and we change the way that we approach things. And the last thing I'm going to read you is how do we change and fix this? So 2 paragraphs. I was working with some nurses in California, and there was a particular nurse named Mary Ann Barnes-Daly who goes by Jet and always reminds me of West Side Story. Jet told me, by the way, she conducted the first multi-center trial that proved that the ABC-DEF bundle could save lives, reduce length of stay in the ICU and hospital, reduce ICU bounce backs, reduce delirium and coma, and reduce nursing home transfers. This bundle of care, which essentially says, every day for you, Ms. Smith, I will check you out to see if your pain is controlled. I'll try and wake you up by turning off your sedation. I'll try and turn off your ventilator. I will see if I can avoid benzodiazepines. I know I can. And I will monitor you for delirium, early mobilize you, and have your family at the bedside. This 6-step humanistic approach, evidence-based, 40 New England Journal, JAMA, and Lancet papers behind it, and over 400 papers supporting the bundle. And here's what Jet told me. She said how she had approached changing the culture in critical care within her hospital system. I went to the ICU with my small hospital, and I told them about the bundle. Here's the A and the B and the C. And I explained everything, and the nurses nodded, I said, so this is what we've got to do. This is the cool new stuff. They said, great, great. 2 weeks later, I went back, and you know what they had done? Nothing. Jet laughed. I could imagine she didn't laugh at the time, though. Trying to sell people on a mortality reduction isn't really meaningful to them. You have to sell patient stories. That was exactly what we had learned too. You must sell stories to get people on board. Jet went on. I went to our flagship hospital, Sutter Medical Center in California, where there was an ongoing ICU nursing meeting. There had to be 60 or 70 nurses in the room, and I had an hour. I spent 40 minutes talking to them about how we were hurting patients, and 20 minutes on how we were going to fix it. I told them what sedation did. I told them what tying patients down in bed did, how they couldn't walk, or have their jobs, or how they'd lost their spouses and their families, how they said they'd rather be dead. I had nurses crying. They thought they were doing the right thing because that's what they'd been taught. Just like all of our current nurses are being taught and all of our current doctors are being taught, this is how you care for patients in COVID times, and it's all wrong. They said, we didn't know. I said, I didn't know. I'm learning all this stuff too, but we're hurting people. We're breaking their brains. So those are my thoughts. I'd love to hear any questions or comments from you. I really think that we know what we need to do. I think we know how to care for patients, and I don't think we're doing it. And so I call on all of us to say, when we're at the bedside, why do we have this patient in a coma? Why do we have them in a bed? Let's go back to what we know works. Thanks.
Thank you very much. Are there questions from the audience?
Don't be bashful.
Thank you. Marianne Crane from Australia. My unit is literally about to, we're starting our project to bring in the A to F bundle. We've got an electronic medical record and we'll be using that to support it. What are your top tips other than having champions to bring the bundle in?
I'll give you 3. 1, keep the motto, what can I do by Tuesday? Because that means that on Monday, you're going to sit together with your team and say, what can we do by tomorrow? So don't think down the road, think tomorrow. What can I do by Tuesday? That's the motto of the Institute for Healthcare Improvement, the largest QI program in the US. Number 2, do not try to climb Mount Everest. Instead, try to climb a hill. So find one patient and one nurse and do that at the bedside rather than changing the whole unit. And change things one at a time, build slowly over time. And 3 is take these early wins, these patients, and teach the others through the power of human story. In this book, Every Deep Drawn Breath, there's a whole section at the back on resources. So you can go there and find tons of resources. And lastly, please feel free to communicate with me anytime. Our website is icudelirium.org, and my email is simple. It's just wes.ely@vumc.org. And there's a thing in room 311 and 312 today at 4 o'clock on delirium monitoring that you could come to. If you want to learn more about delirium, 311, 312 today at 4. Thanks so much.
Thanks so much, Wes. So it's my pleasure to introduce our next speaker, Dr. Susanna Esposito, and she comes to us from the University Hospital in Parma, Italy. And she's going to talk to us about an important topic that we probably don't spend enough time talking about, which is the children and how children can also be affected. Dr. Esposito, thank you and welcome.
Thank you very much, and thank you very much for the presentation. I will speak about COVID-19 in pediatrics, focusing on 3 different aspects. First of all, epidemiology and clinical presentations. Then I will speak about the complications of COVID-19 in the pediatric population, and then I will speak about the role of vaccination. So when we consider the pediatric population, we know overall that among COVID-19 cases, just a minority are represented by cases with complications that require admission in intensive care unit or that are at risk of death. But when we take into account the most important complications, MIC, then in these cases you can see that there is an increase in the number of cases that require admission to intensive care unit and that can have a negative outcome. So the first issue is to define how to manage children when they have COVID-19. Secondly, it is very important to know how to predict the risk of negative outcome in the pediatric population. And when we take into account the clinical characteristics of children, at the end several studies have been done to understand why a large part of them present infection in a symptomatic way. The most accredited theory is the one that considers the underexpression of ACE2 enzyme receptor so that the virus has difficulties to enter children's cells. Then there are other differences probably in innate immunity, in recent exposure to antigenically similar viruses, the other coronaviruses, and then even other factors. However, we also know that with the variants there were some differences because at the beginning with the wild virus we have very few cases in the pediatric population, even within the same family. At the end, we observed that a large number of children were not infected at all. Whereas with viruses with a higher transmissibility, then the increase in the number of cases in the pediatric population was observed. And this means that at the end, the children are not really protected by COVID-19. They for sure can be infected. They have probably, especially not the adolescents, but the younger population, a lower exposure, but they can be infected within the family or anyway within their contacts, for example, in schools or in this kind of settings. Then, however, I think that we should focus on the first point, how to manage these children. It is very important to remember that asymptomatic children should remain at home, isolated at home, but without any kind of treatment if they have no symptom. Whereas in the other cases, symptomatic therapy is recommended. That means just paracetamol or otherwise ibuprofen, but just for the treatment of symptoms, not as a standard therapy. Then in case of cough or in case of the need of inhalation therapy, it is important to remember that in order to reduce the spread of the virus, it is useful to use the spacer instead of the aerosol therapy. And the other point is to guarantee an appropriate hydration. And finally, to remember that antibiotic therapy is not needed. This is an important point because usually the disease is mild, and so it is very important to avoid antimicrobial treatment and especially the use of azithromycin that has not been associated with any kind of clinical benefit in this population. This is very important because, for example, in Italy, a few months ago, we were without the availability of azithromycin because it was largely used in primary care setting. And then, however, you can say, but when we should consider that the children are at risk of negative outcome? It is true that those with underlying disorders are at increased risk of negative outcome, but it is also true that the MISC is a complication that is frequently observed, that can be observed in otherwise healthy children. So the presence of underlying disorders is an important issue, but it is important to remember that only specific conditions, at the end, this risk is observed. And in fact, if we look at when there is the recommendation to admit the child in pediatric intensive care unit, it is true that, for example, when the CPAP is needed, it is important to be in a hospital with the pediatric intensive care unit because the worsening of symptoms can be very fast. Then it is true that in case of multi-organ failure, in case of shock, in case of coma, it is important to be admitted in the pediatric intensive care unit. But at the end, in our experience, and I mean in the literature, the probability of having respiratory failure is lower than that to have the failure, for example, of the heart function. And so we suggest to monitor in children that are hospitalized in the ward the heart with echocardiography, because when there is the involvement of the myocardial tissue, you can observe a progression and you can observe the need of supportive care that can be just performed in the PICU. Then, anyway, as I said you before, we should remember that in the presence of specific risk conditions, then we should consider that there can be some comorbidities that increase the risk of hospitalization and negative outcome. This is the experience with cystic fibrosis. It is true that considering the data overall, the risk of hospitalization and admission in the ICU is higher in cystic fibrosis patients in comparison with the general population. But this risk is observed mainly in lung transplanted patients. So again, in this population, this means that the high-risk patients with cystic fibrosis are those who receive a lung transplant, are those with severe malnutrition, are those with moderate to severe reduction in lung function. And this explains why in Italy, at the end, we worked on a guidance for the use of monoclonal antibodies that restrict their use to a selected population. So not only those with BMI that can just highlight the presence of overweight, because otherwise 30% of the pediatric patients in Italy have overweight. But we just consider obesity, we just consider cystic fibrosis in presence of comorbidities, and even in primary immunodeficiency, we do not consider as severe the presence of IgA immunodeficiency or IgG, but just the severe conditions that can really benefit of this kind of approach. Why this? Because at the end, you know that there isn't any experience on the use of monoclonal antibodies in the population below 18 years of age. Then they have been approved starting from the age of 12, but without any kind of data to support. And so our position is to limit the restriction to the children and the adolescents that can really have benefit. Then, however, we should remember that MAC is a complication that involves at least 4 different organs, and usually in the pediatrics, it involves the heart, even the central nervous system, gastrointestinal system, and also, in some cases, the respiratory tract. Usually there is pneumonia, but without respiratory failure. This is what we observed most frequently. And in these conditions, the approach is to control the inflammatory response that is characteristic of this form. So usually the double treatment with intravenous immunoglobulin plus intravenous steroid is recommended therapy. According to WHO guidelines, even immunoglobulin alone can be used in these cases that are Kawasaki-like syndrome-like, so just with the heart involvement, without the involvement of the other systems. But if you have the involvement of more than a heart, then the double treatment has proven to be better than the monotherapy with intravenous immunoglobulin. Some groups use just steroids, but I suggest to follow the standard guidance with the double therapy. Then, of course, in these cases, it is important also to look at the dimer, because the anticoagulant therapy is useful. And regarding the other kind of drugs like anakinra or tocilizumab, there are now some experience, but I mean just some case reports without any kind of trial that have tested the combination therapy for the management of MISC. But they can be used when the cytokine storm is huge and the treatment with intravenous immunoglobulin and intravenous steroids seems not enough. With remdesivir, that can be limited to complicated cases. It is quite interesting that in the neonatal population, we do not have any kind of MISC, and so the neonates at the end show a course of the disease that is quite mild to moderate without any kind of severe complications. So this is a manuscript of the group of Mike Levine. This is a multicenter study showing that the combination therapy with intravenous immunoglobulin and intravenous steroids is an advantage in comparison with intravenous immunoglobulin alone. But there are trials, as I said before, using the biological drugs. And anyway, I think that if these are the risks of COVID-19, we should remember that COVID-19 in the pediatric population can cause also long COVID. how much long COVID is caused by the virus itself or by the pandemics and all the restrictions that the pandemics have caused, this is not completely understood. But our recommendation is to check to new symptoms after 4 weeks from the disease, even in a symptomatic patient, then to monitor again after 3 months the children, and to consider long COVID when you have 2 months of symptoms after 3 months from the onset of the disease. So this means a long duration of specific symptoms and after at least 3 months from the beginning, from the positive swab. With the need to be careful with the data coming from the different studies, because if you look at the studies in the literature, they come mainly from self-administered questionnaire, and the prevalence is huge, so the change is between 4% to 42%. The point is to monitor the patient after the disease, because it's true that sometimes some symptoms occur, and this seems to occur mainly in adolescent age, in the female gender, and in those with chronic underlying disease. When we look at the symptoms, in the majority of the cases, these symptoms are neuropsychiatric symptoms, or we can say psychological symptoms, as concentration difficulties, difficulties in attending schools, sleep disturbances, irritability, headache, and sometimes this creates very important problems in the quality of life. With other kind of symptoms as chest pain or dyspnea or cough that are observed in a minority of patients. And then with abdominal pain that can be observed. You know, abdominal pain is something like the irritable colon that we have, and in which the mind, of course, has an important role. The point is that the inflammation that is caused by the disease may explain some of the symptoms, but it is also true that the restrictions and the type of life can have an impact in this kind of disorders. So the question is whether long COVID is really caused by SARS-CoV-2 virus or by the pandemics itself. And we hope to be able to answer to these questions in the future. One point is that there are some data now coming from specific studies showing that the immune dysregulation that is observed in long COVID patients can persist up to 8 months after the disease. And so this is, again, another interesting point that should be studied in the future. But when we consider the respiratory function, at the end, this appears very similar in patients that have long COVID and in those that haven't it. There are just few case reports that reported some differences in perfusion, but I mean just some case reports. Whereas other kind of symptoms are very specific, with the possibility then that in presence of problems like comorbidities, especially psychological, underlying psychological problems, the risk of having long COVID is even higher. So, if these are the problems, we should remember that another important issue is represented by the psychological impact that COVID-19 has in the pediatric population. So, if we look at the data coming from different countries and in our common experience, the temporal trends in the suicide is really huge. Our wards, I am a pediatrician since more than 20 years, and our wards now are full of people with severe neuropsychiatric disorders. So suicide, then problems like anorexia. So these kind of issues really increased a lot in this COVID era. And this means, again, that this is a problem related to COVID-19. For this reason, I strongly support the vaccination of the pediatric population in order to reduce the COVID risk that can occur even in otherwise healthy children, in order to reduce long COVID, in order to permit a life that can be normal, we can say. With data coming from vaccine trials showing an efficacy higher than 90%, and then with safety data that are very good in the pediatric population. Of course, some reports regarding myocarditis are available. It is true that the risk of myocarditis after vaccination is 0.0000 4%, and this occurs mainly, that means not just only, but mainly in males with the second dose. In fact, when you look at the increased risk of myocarditis, you can see that this increased risk is especially observed between the age of 15 to 25 years, with a risk that is more than 2.5 more in the population of males. But the benefits at the end are great, and the vaccine can be co-administered with other routine vaccination, because we should remember that in this COVID era, we observed a decrease in vaccination coverage for all the diseases in the pediatric population. So how can we conclude? I think that we strongly support the vaccination, and also I think that we can remember that pediatric COVID should require symptomatic therapy and should be managed at home. The MIC is a severe complications that require admission to intensive care unit in the majority of the cases, even for the monitoring. The management of long COVID require a careful standardization, because long COVID is a problem in pediatrics, but we need to know something more about it. And vaccination against COVID is the only way that we have for overcoming the pandemic in the pediatric population. Thank you very much for your attention.
Thank you very much, Dr. Esposito. Maybe in the interest of time, we have the opportunity for one quick question. Is there anyone from the audience who would like to ask a quick question? Maybe I'll just ask a quick question, Dr. Esposito. I think the data you show in particular on mental health in adolescents is such a strong, hopefully, motivator for vaccination. Is this more of a strategy within pediatrics to promote vaccination to mitigate long COVID rather than acute infection, which really seems like a relatively rare problem in children?
This is a very difficult point, because I think that when you have a child with mental health, there is the stigma of mental health. So the family tries to, cover this kind of issue. And even in the society, if you explain that now the pediatric wards are not full of respiratory infections as usual, but are full of children and adolescents with mental problems, and the problems are not, mild problems, but they are severe problems, then this creates a bit of confusion in the population. So, for example, in our experience, we are working in doing some welfare programs in companies, but not medical companies. For example, in different activities in the societies to family, to explain that these problems are very common and to strengthen the need of vaccination. But I think that in the population overall, in the newspaper, for example, at the end, the idea that vaccination should be done for the direct effect on the disease remains the most important point. And so we are trying now to work in improving the awareness on long COVID, because I think that long COVID is closely related to the psychiatric morbidities, so that in this way we can try to increase the level of coverage. Also, what I can say is that at the beginning of the campaign, the coverage was huge, whereas in this phase, at the end, there was a reduction in the number of vaccination observed among parents that are hesitant.
Thank you.
Thank you again, Dr. Esposito. Our next speaker is Stephen Brett. He comes to us from London in the United Kingdom. Hello. And he'll be speaking on experiences of healthcare workers on the front line.
Morning, everybody. Thank you very much. So, 10:53, 50, oh, we've got a clock. Good. So I don't have any disclosures for this particular conversation. And what I'd like to do is just tell you a little bit about some work that we've done at Imperial over the last few years on behavioral aspects of staff and staff psychology. So we started this work some time ago, and we published this paper in critical care medicine. And this sort of sets ground zero for the experience of intensive care staff from all professional groups during the COVID thing, which is my brief this morning. So this particular study, we started off looking at the stress that was induced by staffing challenges amongst senior intensive care staff. That was our starting point. And we actually conducted this as a qualitative methods semi-structured interview project. And as is often the case with these things, where you start and where you end up are sometimes not quite what you anticipated. So we had a staffing basis to our study, but the interviews that were conducted by one of my colleagues were very emotionally challenging interviews. The vignettes that we'd used to allow people to tell their stories actually took people often to very uncomfortable places, and we were able to deduce quite a lot about what the experience was like of ICU staff, and in particular nursing staff. And we came up with a thematic analysis, which I've summarized for you on this slide. So this is freely available, I think. We paid for it to be open access. And, but what we have here is, first of all, people's approach to their work is very heterogeneous. But there were a few things that were worth highlighting. First of all, amongst our staff, we have some people who are very perfectionist in phenotype. So they come to work wanting to do one thing to a very, very high standard and not to be distracted by extraneous factors. And then we have other people who are more pragmatic, who have a more sort of adaptable approach to things. Another thing that we found was that quite often people have, amongst their working colleagues, they'll have an A team. So there are people who they know, they've worked with before and they trust. And they will feel pretty invincible if they show up in the morning and they see familiar faces that they know that can help them through a challenging shift. Weirdly, often the perfectionists liked a team of pragmatists around them, so because that allowed them to focus on one particular aspect whilst their colleagues mopped up the havoc. Another thing that was interesting was that not everybody likes situational awareness. So we use that as a sort of safety mantra. Everybody's got to be aware of everything that's happening. If you're a perfectionist, you hate this. You don't want to know that there are 3 patients in the heart attack center, there's a trauma call, all the rest of it, because that unsettles your own particular mental model of doing things. I think those were probably the main things that are relevant to our future work. So this notion of perfectionists versus pragmatists, people have an A team, and then situational awareness is something that, that troubles a lot of people. But that led us to a hypothesis, which was that people who work in intensive care departments might be phenotypically different in terms of personality to those who work in other departments in the hospital, in particular the emergency room. Where obviously you've no idea what's coming through the door, you have to be to some extent very adaptable. So we designed a project to explore this based on doing personality profiling in parallel to a qualitative interview-based project in both our critical care units and also in our emergency rooms. And we had this guy just across the start line in September 2019, and we just started to recruit to this when COVID hit. So we were primed across the start line, everything in place to do a lived experience study of our staff's experience of working through the challenges of COVID. So it was just, for us, with minor modifications, we were actually ready to roll. And with Kate Grayley, who's one of my PhD students, so she conducted a large series of interviews alongside the personality profiles. We ended up interviewing 58 people in real detail, and we hit saturation at about 40 interviews. And our COVID subset, we had 49 interviews. So we were well across a good data margin for a qualitative-based study. And we were able to conduct a pretty detailed thematic analysis from which we learned a great deal. Much of it we weren't anticipating. So that's just a summary of the study. We don't need to get bogged down with that. So these were our 5 overarching themes that we identified. We had psychological effects, changes in team dynamics, changes in experience of psychological safety, the working in an environment which was dominated by protective equipment, and also changes in workplace stressors. And these things were the basis for a more detailed sub-theme analysis, which I'll just highlight some things for you briefly. Again, this is published open access, so you can easily get hold of the full manuscript, which has a lot more detail in it. So first of all, the psychological effect. Well, perhaps not surprisingly, people found the whole experience rather difficult. Many of them, this is in the early phases, had fear of the disease themselves, fear for their families, feelings of isolation. I'll just highlight the notion of moral injury, which I'll come back to in a second. But the psychological effects also included the fact that they were dealing with an unknown thing. No one had evolved proper coping strategies at this stage. And we also did see differences in personality type having a bearing on the experience of distress that people experienced. And in the UK, at the end of the first wave, then there was this massive panic to try and catch up on lost elective work. So indicators of moral injury. So moral injury sounds quite nebulous and to some extent technical. And what it actually means, for those that are interested, cognitive or emotional response that can occur following events that violate a person's moral or ethical code. So this means this is an experience which people have when they find themselves part of an enterprise which challenges their own particular values. Now, we had come to rely, or we had assumed that we could rely on our senior nursing staff and our senior physicians to lead this whole thing, and that their experience would somehow take them through. But in fact, many of these people experienced greater moral injury than everybody else because they had decades of experience of doing things to a very high standard, and suddenly a very high standard was just unachievable and adequate was just fine. But if you've spent 20 or 30 years as a critical care nurse trying to achieve excellence, then having to bargain down to adequate, where we had one critical care nurse, plus another nurse, plus 6 people who weren't qualified in any healthcare discipline, looking after 8 patients in a pod, we called them. These pod leaders had very substantial stress associated with this, just because they were having to shoot at adequate rather than excellent. And in fact, there's a link at the end of my presentation, which is to a thing on Health Education England's website, which deals with this in much more detail. But moral injury for a lot was very substantial. I had never, in 30 years as a critical care physician, had to sit down with senior nursing staff in floods of tears in the middle of the day and try and counsel them to help them move forward and get back out there and tell them that they were doing a fantastic job. That was a unique experience. As in fact, the oldest person on our staff pretty much, then I'd never experienced that before, having senior people in floods of tears in one of our offices, needing to be boosted before they could go back out there. That's had a long legacy. We have lost a lot of our people, as I'm sure everybody has. So that was interesting. We had changes in team dynamics. This was characterized by quite a clear flattening of hierarchy for 2 reasons. One, nobody had any clue what they were really doing, so there was no unique knowledge set that the senior people had. So that tended to flatten the hierarchy a bit and paradoxically increase a sense of psychological safety amongst some. But also, we'd had to outsource leadership to members of our team who wouldn't have previously anticipated being in leadership positions. So lots of, particularly our nursing staff who just qualified through the critical care course and were not yet secure in their own professional space, suddenly they were pod leaders. They were reinforced by people from British Airways, from Tesco's, from the local nail bar, people from the military. They were having to form AIRSAT critical care teams to go out and do things. And that definitely, that outsourcing of leadership down to a very low level, some people thought that was fantastic, other people were not ready for it. So there's a very mixed response. So changes in team dynamics was quite an important thing, as perhaps many of you will recognize. So the psychological safety thing was interesting in itself. So some people felt a greater sense of psychological safety because we were encouraging people, we were managing what's called safety voice in a better way. We were encouraging people to speak, We wanted them to come to us so that we could learn collectively. The challenge was that our environment was wrecked. So all of the spaces where people might have quiet conversations and say, come to us with their particular concerns, had been turned into storerooms. And actually communicating effectively in PPE was a huge problem. And if you remember, going back to one of the original slides, people feel comfortable when they see their A team around them. But when everybody is wearing exactly the same stuff with face visors, masks, the whole thing, then that sense of losing who you're with was really, really quite important. And in fact, in some places, people took photocopies of their pictures and glued them onto the front of such protective equipment as we had. It didn't work so well on bin liners. So, just to summarize that, voice was empowered, but there were practical difficulties in maximizing that. I think that's something that we've learnt and that we would take into any future nonsense. The whole thing with PPE was a major thing for many staff. Many staff had not worked in that intensity of PPE before, and they found it reinforced their personal feelings of vulnerability to some extent until they became confident in it. And in the UK, we had long periods where actually we didn't quite have the PPE that we should have had, in spite of what the Secretary of State for Health was telling the media, and that really, really didn't help. Workplace stress, I won't get stuck on this, but we also, I think one of the things that contributed to this was constant change in what was regarded as best practice as the evidence base for what we were doing evolved. And that left people feeling constantly unsettled. So we were able to meld this into a sort of matrix, a context matrix, which allowed us to identify areas that we would focus on moving forward. And in fact, we were able to apply some of these lessons in subsequent surgery. Sorry that you need a bit of a telescope to read that, but as I say, it's freely available. But most of the themes that we were able to identify, we were able to also identify relatively straightforward mitigating factors that if leaders were aware of, they would be actually able to make quite a clear difference. So that was quite a useful thing. So from a leadership point of view, we had made some assumptions, I think, which were wrong. So the assumption that senior people can lead without becoming embroiled in their own emotional turmoil was a big assumption that was wrong. And I think that's, for me, was a lesson which I learned pretty quickly. But I think it's something that I think we should take forward. A lot of the psychological effects, once you know about them, you can probably manage them a bit better, or you can help people. We found that there was a real heterogeneity in people's responses. Some people thought that it was the best thing they'd ever been part of. It really met their ambitions to be critical care staff, and they rose to that challenge in a very positive way in spite of all of the exhaustion. But a lot of people didn't find that. They found it incredibly difficult and challenging. As I say, we have lost a lot of people. And we think that probably, because we've now had a chance to analyze the personality type data, which isn't in this paper, that there is a role for personality type in mapping onto people's phenotypic response to a challenge such as this. So we found that in the intensive care staff who are more likely to be of the perfectionist phenotype, those individuals need quite a lot more upfront support, whereas people who are emergency room staff, although they had a different set of challenges, they're more likely to be people of a pragmatic tendency. So it's not that they like chaos, it's just that they're reconciled to chaos, and what they like doing is creating order out of chaos. And with that, I think I will stop. Thank you very much for your attention.
Fantastic. Do we have any questions for Dr. Brett?
Thank you for your excellent literature. I found it very interesting. But as I understood, it was only done about after the first wave. Do you have any longitudinal follow-up?
No, so the analysis that we've presented here was predominantly the first wave, and there were some of the interviews were into just the start of the second wave, where in the UK we still hadn't got complete vaccine coverage by any means. So there were some differences, but not hugely at that point. I think if we, the third wave that we had in the UK, which was basically January, February this time last year, had a whole different series of challenges. So we had far more cases in critical care. We had to put in pop-up intensive care units in normal wards, in bike sheds, broom cupboards, wherever we could find them. And the whole thing was, well, I think, dominated by a different set of challenges. So I think if we ran the analysis on that, we would find some differences. Okay, thank you very much.
Thank you very much.
Thanks. And our final talk this morning is from Dr. Victoria Metaxa from King's College London. And she's going to talk to us about the role of the family. And thanks so much for this, and we look forward to your talk.
Thank you very, very much. So, so I'm just going to tell you a little bit of what I'm sure you know about the impact of COVID on our patients' families. So I'm going to struggle with this, of course. Right, so no conflict of interest pertaining to this talk, of course. This is all pre-COVID, and I'm well aware that we come, thankfully, from different countries. So the involvement of families in patient care is very different. The time they visit, the way they stay with their patients, the way they participate in patient care. This is from 2017. This is the narrative review by Judy Davidson, Randy Curtis, and many more people that basically gives guidelines for family-centered care in ICU, well, in all sorts of ICUs. And they came up with 23 recommendations. I'm very quickly going to go through what I think were the most important ones. So first of all, family presence. So family presence in ICU, they do suggest that we have open or flexible family presence, and then again, please take that with a pinch of salt if you're coming from a place where that's not the norm, because that, and active participation of families in patient care, because they have found that, hold on, no back? Sorry about that. Doesn't matter. Is he there?
We had some problems.
We do, but I don't know how to go
lift it
back.
up a bit and press.
There is, I do.
Seems like
Where they directed it.
it
perhaps.
seems a directional. yeah.
Sorry. Apologies.
I think it's where you point it. You have to point it at the screen.
All right. Brutal force. Thank you very much. Yeah. Thank you very much. Sorry about this. So anyway, so yes, so be there, be flexible, because if they're there, if they participate in patient care, that definitely improves satisfaction, reduces conflict. Have families there when you during resuscitation. Talk to families early in a multidisciplinary form, because again, that increases satisfaction and reduces conflict. And also, they advocate the value principle, and that's from Randy Curtis again and Doug White, as a way to talk to families, like actively listen to what they're saying, be supportive. And what I've highlighted there is just ensure that they have feelings of non-abandonment. And of course, this with COVID became very, very, very pertinent. And of course, systemic suggestions, so you make your ICU organizationally friendly for the families to stay there, to visit, but also to stay over if they want. Have families, have readily support for the families, but also for the staff, because it's not very easy to have families around 24 hours. So this was before the pandemic, and this was also quite known. So when humans encounter large-scale disasters, so both their individual stressors and organizational stressors intensify. As also, human needs to feel safe, connected, calm, useful and helpful also intensify. So in the same time as we were entering this major disaster that COVID was, the precautionary principle came to play, and that says that, again, during crisis management, is not necessarily appropriate or needed to have fully validated evidence in order to institute policies that reduce the perceived risk to the public. So I'm sure you see where I'm getting through this. So that clearly resulted in restriction of family visiting, but also skepticism, fear, and anxiety in the people that were isolated. They were isolating at home, they were isolated in the hospitals, they were isolated in ICUs. So suddenly, an almost absolute restriction to visitation was enforced. I mean, at least in the UK, but I also know in other countries as well. And that, of course, could be explained initially in the first wave. It could be explained because we didn't really know how the virus was transmitted. Dr. Brett talked about PPE shortages in the UK, and I'm sure elsewhere as well. And because our staff was really, really busy. And of course, having a family there, we all know, takes a good amount of the staff's time. So for all of this, family-centered care was deeply challenged, especially during the first wave of the pandemic. But that was one of the things that really continued as things got, even when things got better. So this is something we did at King's, and we looked at how a family liaison team, so that was a team by consultants, but non-ICU consultants, so predominantly orthopedics and radiologists, God help us all, that instituted to help us with communication with the family. So we then went and interviewed family members, and we found 3 predominant themes. So we did find that being there or not being there with the patient and for the patient, so as a patient's advocate, was very important, and that was taken away from them. That increased their anxiety considerably. Guilt featured very strongly there. Guilty for not being there, guilty for feeling fear and not really wanting to be there, but also wanting to be by the patient's side. Everybody was very, very thankful that we had video calls, and that was an opportunity to at least see their loved ones, but everybody said that, well, this is not the same. The second theme was breakdown in communication. So multiple people, although they were very thankful, they also identified breakdowns in communication. And of course, I think that's, again, easily understandable. These people were not critical care consultants, they did their best. But they focused a lot on, you know, the FO2 is this day and that the other day, and missed, I think, a little bit of the bigger picture. And of course, this was highlighted and became much worse during end of life. The last theme was that of disbelief, and that was disbelief at the speed of deterioration. Remember, the majority of these people, the last time they saw their relative or their friend was at the back of an ambulance, not being able to breathe, and then the next thing they hear is, do you want to come in? They're dying. So we had a lot of families saying, you know, I know you tried, but I'm sure there's some foul play. I'm not going to do anything, but I'm sure you did something. It's impossible for them to have died like this. So we were not the only ones, of course, that noticed it. Many other centers and many other colleagues published on this, and they published on this about, you know, how not having families there and video calls lost your, you know, your human contact and your non-verbal skills. The family's anguish in not being there around end of life. Delirium, and Dr. Eli talked to us about the impact of not having families there, and that increased patients' delirium. I really liked this study. This is from Johns Hopkins in the US, and what they did is they looked at 500 patients, and they looked at pre and post the implementation of a restriction in family visiting, and this is what they found. They found that length of stay increased by approximately 3 days, but also the time to reach a treatment escalation plan or DNA CPR order was also almost doubled. So not having families there was not only detrimental to the families, but also to our decision making, especially around end of life. So what can be done about it and what has been done about it? This is a very recent systematic review. They looked at about 200 articles and they in-depth looked at 24 of them, and they found 4 things we've done. First of all, we altered the way we communicate. I'm sure we all know that. We use the telephone much more, we use video calls much more. Multidisciplinary interventions, and other speakers talked about this, so we called in help from other specialties, so palliative care team and social workers, and we use those people to support us as staff, but also the families. Other centers, not us, engage the families, so virtual ward rounds and telephone communications during ward rounds, and there were several studies that focused on family support with early detection of any psychological sequelae and offering them psychological support. So this is from another study. That was another study we did UK-wide. We sent questionnaires in all of 217, I think, ICUs that had at least, hospitals that had at least one ICU in the UK, and we looked at what they have done during COVID. And what we found is that, again, as expected, almost 99% of them had formed some form of virtual visiting. About 50% of them had a special team and not ICU team to do this communication. But I think here, I'm not sure you can see this up here. So these are the indications of not having virtual visiting. And here you can see that patient unconscious or sedated was listed as a reason for 23% of the ICUs that replied. So we identified some issues. So first of all, yes, virtual visiting is great, but you need stable access. You do need to have a smartphone that works and people that remember the password. That's also very important. Again, where King's is, it's quite a challenged area, let's say, and we have identified that clearly that introduced some age bias. So young people that had younger family members were the ones that could just, handle the device and easily make video calls. People had to have a smartphone and had to have data to use on that smartphone. And a lot about information governance. So it's interesting that the Intensive Care Society in the UK, one of their guidances cautioned us against using video calls for patients that were comatose. I think that was largely ignored. So what about more proposals? So this is from Joanna Hart. This is again a review. So basically, and it's in the same format that I started, because some of the things are similar, aren't they? They do say, have families in, at least 2 people. Don't use exceptions. Don't only have families when the patient's about to die. That doesn't really help anyone. If you don't allow families in, please tell them why, and be very clear and very transparent. Use alternative, use a virtual, use a hybrid form of visitation. Again, then involve the families, ask them, do they want to visit, when they want to visit. It doesn't always have to be a very close family member. Have your hospital and your organization support you. So this may be a central command to organize all these visitings. I'm going to finish with this. This is from Nancy Curtis-Burns and Ellie Azulay, a 5-point strategy to improve connection with families during COVID. It doesn't really tell us anything we haven't said yet, but what they do advocate, and I thought that was quite good, is when you speak to the families that can visit, please keep a schedule. We will call you at some point during the day. Was found to create great anxiety to families who, especially during lockdown, have nothing to do but be next to the phone and wait for us to call. So to conclude, the pandemic, I say here, has the potential to set back family-centered care. I think in many countries and in many centers has actually set back family-centered care decades. We know now, and we keep finding more evidence, that separation is devastating for patients and families. The good thing is that we now have alternatives to inpatient visitation, the hybrid model, which I think works very well. Next time, and I think Dr. Brett said that as well, next time we talk about PPE, please remember that not just us, doctors and nurses, need to wear that. And also remember, just be transparent and considerate or when you exclude patients from ICU for any reason. Thank you.
Thank you.
Record time.
Thanks very much, Dr. Metaxa, for an outstanding review. It's 11:23. We have time for one quick question and a quick answer if there's anyone who would like to pose something from the audience. Maybe I will very quickly, Dr. Metaxa. There's been a de-adoption of so many practices, and Wes, reviewed that nicely in the context of delirium. How are we going to, this actually isn't a short question, but maybe you can give me a short answer, but what quick strategies or what strategies can we use to readopt what we've spent decades understanding is vital in terms of management and about visiting? How do we bring that back in?
Thank you. That was a short and easy question.
Yeah.
Thank you for that.
Yep, you're welcome.
So I think it doesn't help that the fact that at least in the UK, at least, I'm not going to generalize, we're not back to normal yet.
Yeah.
I don't think that helps anything. So just expecting everybody, and especially our nursing staff, that I think we've said this a lot in this session, have been hammered during this, to just go back to normal, I think it maybe asks for a lot. I was hoping that COVID might have been this just circuit breaker and everything would have been much better after this. I'm not so sure. I think many standards have slipped. But I think maybe we should be kind to ourselves and slowly get back to normal, and then we will find our way back. I don't know. Yeah. I'm not sure. I despair.
Thanks so much for that.
Thank you.
And on behalf of my co-chair, Dr. Gershengorn, thanks for a great session this morning, and we'll turn it over to the next series of talks. Thank you so much.